A very good morning and warm welcome, everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's Oral Health Summit. Organized by Voice of Healthcare and powered by Haleon Sensodyne, this summit is dedicated to exploring the latest trends, innovations, and best practices in oral health. Throughout the summit, we will bring together leading experts, dental practitioners, researchers from around India to share their insights and experiences in the field of oral health. We will cover a wide range of topics from the latest advancement in dental technology and oral surgery to the impact of oral health and overall health and well-being. Moving on, I would like to welcome our chief guest for today. I welcome Dr. Sandesh Maikar for inaugurating this Oral Health Summit to recognize Oral Health Day, that is, be proud of your mouth. Over to you, Dr. Sandesh.
Hi, it's so nice to be on Oral Health Summit on the day of World Oral Health Day. That is 20th March of every year is World Oral Health Day. And FDI, that is Federation Dental Internationally, which is a international body, world body of dentists, where all the association join, has given a slogan or the tagline for World Oral Health Day is "Be proud of your mouth." Now, proud, what is the meaning of proud? Proud is that you are satisfied with what you have and you are happy with what you have, and you really would like to show what you have. So you say that I'm proud of my son, or I'm proud of my daughter, or I'm proud of this, proud of that. Similarly, be proud of your mouth is a slogan. And to be proud of your mouth has to be very healthy. So, what's the importance of oral health, first of all? One should know the importance of oral health, and then you will know how to maintain and how to retain the health of your mouth from the birth to the end of your life in this world. I just want to give us sort of an example or just something for you to do, all of you, those who are listening. Just close your eyes for 2 seconds. I'm closing it. When I close my eyes, I can't see anything, but I can do everything. I can run, I can walk, I can talk, I can eat, I can do everything. Now open your eyes and then you think that you don't have teeth in your mouth. Wow. What can you do? So, friends, the nutrition which a child gets for growth and development and elderly for their energy comes from digested food. And to digest the food, you have to chew the food. It's not the diet. One of the renowned dietitian was taking my interview, and I just told her, Rujita, your diet is useless for me. She said, what? I said, if I don't have teeth. So teeth are very important. Chew the food, and unless you chew the food, you can't digest the food. So you need healthy teeth, even if you're a child, and you need healthy teeth, even if you're old. The concept of old people that I'm 70 plus, अरे एक दो दांत गए तो क्या हो गया? If I lose one or two teeth, what's the big deal? I've got 28. So I show them 10 fingers and I tell them that if one or two fingers goes at the age of 75, what's a great deal? You have got others 9 and 8 fingers. Why no organ of the body falls down? Only why the teeth has to fall down? The reason is oral health maintenance is taken for granted. You will send your car for servicing, any vehicle, two-wheeler, two four-wheelers, or even a plane, you send it for servicing. But why don't we service our own mouth? We use your mouth for liquid, hard, firm, fibrous, cold, hot, warm. Day and night you use your mouth, but you never service your mouth. You take it for granted that we have got 32, it's okay. I can even eat from one tooth, or 3 teeth, or 5 teeth. There's a difference between chewing and eating the food properly and swallowing the food. Unfortunately, those who swallow, I would like to remind them there are no teeth in the stomach to chew your food. And then your stomach get distended, etc. So if you find any person who is not healthy, you will see that they don't have teeth in their mouth, or their teeth are not healthy, the mouth is not healthy. The importance of oral health again lies in systemic disease. Like any swelling in the gums, where it is, we say, bloody mouth, bloody gums, that there's a lot of circulation in the gingiva, that is in the gums, and if they get swollen due to inflammation, the bacteria from the mouth can go into the capillaries and then can affect your brain, that can affect your heart, that can affect your lung. Pregnancy will be a problem. So systemic problems can start because of infection in the mouth. And if you got infection in the mouth, you swallow that, well, the whole system goes for a toss. I still remember Virat Kohli's interview. He said that he was asked that why did you convert to vegetarian? He said that, well, I suffered from a lot of acidity, and once he was playing, he got pain in the neck, in the backside, because of acidity and indigestion, etc., etc. And mind you, the similar experience I got. So if your stomach is not right, the whole pain starts in all over the body, and that's the reason we should say, I personally say also, tooth is not attached to body, body is attached to tooth. So any problem you have in the mouth can go all over the mouth, all over the body. So हिंदी में कहा जाए तो जब तक खाना खाना है, जब तक जीना है, तब तक खाना खाना है, जब तक खाना खाना है, दांत की जरूरत है, and दांत की जरूरत है तो डेंटिस्ट की भी जरूरत है as a servicing, at least as a service. There is a difference between medical and dental. Medical is apple, dental is orange. You go to medical doctor only when you get pain. But unfortunately, all of us, including a lot of dentists, feel that dentistry is next to medical or below medical because of the NEET exam, that they get less marks and they go to dentistry. That's not correct. Medical is Ayurveda, Unani, allopathy, and homeopathy, whereas dental, where it lies, it doesn't lie there. Dental is absolutely different. You go to medical doctor when you have a problem, but you should go to dentist without problem, because dentistry is mainly prevention. If you have a stomach ache, you don't know whether it's a gases in the stomach or a heart problem. So you rush to a doctor. And it's easy for you. Every human being can diagnose the problem in the mouth because you just open your mouth and you see the problem. So dentistry can be, any issues in the dentistry can be prevented. And that's the most important aspect of dentistry. And teeth can remain, teeth should not fall down even if you become 80, 90, or even 100 if you make. As I said, if you are having missing teeth and not replaced, your diet will be a problem. But if you are missing teeth, not replaced, can give you headache, migraine-like headache, neck pain, shoulder pain, all the problems which 95 to 99% of people don't know, including dentists. Nowadays, dentists are knowing that after we introduce TMJ orofacial pain. So missing teeth can cause this type of problems. You go to medical doctors, you get tinnitus, you go to ENT, but the problem lies with the dentist that your oral health is not maintained, and that is the biggest problem you have. So there's an article, one tooth missing, not replaced in time, can give you headache. Similarly, my thesis for MS in TMD orofacial pain, I found 39.9% of people having headache have missing teeth. So that's the problem of missing teeth, that can give you headache, neck pain, etc. The other problem is, we say, maintenance. People in India has got a habit of eating tobacco, supari, etc., smoking bidi the other way around, and that can cause oral cancer. But you can still prevent oral cancer, but not sending, oral cancer. You can prevent it if you know it is a precancerous condition, and it's easy to know. Did an experiment with one a fruit wala. He was having tobacco in his mouth. So I went to him and I said, "What are you eating?" He said, "साहब छोड़ो ना, मैं हम 8 लोग हैं, 6 लोग तो ऑलरेडी टाटा में जाके आए कैंसर सेंटर में, अभी क्या आदत लगी है." I said, "मैं तेरे को खाने को बंद नहीं कर रहा. I'm not telling you to stop. Keep once here, keep once here, and every day just watch if you get a white patch. If you get a white patch, just rush to a doctor, dentist, and remove that white patch." Because habit is something called body memory, and you can't stop anybody's habit. Intelligent people smoke, they know what's the problem of smoking. But habit is called body memory. So maintenance, I told him that. I went to the same place after 3 months. He said, "Doctor Saab, kuch nahi hua hai." The point is that making awareness of precancerous condition for those who got habit. And we did dental checkups in different parts of the country, I mean city, a nearby city, and we found that students of fourth standard and fifth standard start eating pan masala. So we asked him, why are you eating pan masala? Like every human being has a mentor, they also have a mentor. And their mentor was their parents, their mentor was their uncle. So if uncle is eating, they're also eating. So the best thing to prevent oral cancer is to see that nobody starts the habit. And then, of course, other conditions which we are doing. So that's about oral cancer. So that's the maintenance. And you have to brush, of course. I always say, I don't say twice a day, I say once a day and once at night. And night brushing is very important. Then use the right toothpaste, use flossing. Even, in rural areas, today's scenario of dentistry in this country. Well, when I joined dentistry exactly 50 years back, and I graduated and started my practice 40 years back, that time dentistry was only extraction, scaling, and dentures. Today, there is a lot of advancement. Why advancement? Because people have realized technology like social media, Google, all these things has given information to people about oral health and what dentists can do. So cities, a lot of people still go to a dentist. But if you ask me, lots have to be done to make people aware the importance of teeth, especially in rural areas. Their teeth are very fine. They don't have cavities, but they have got gum problems and maybe due to habit, some other issues in the mouth. So lots to be done to educate people about importance of oral health. So today's scenario is this, that cities are doing well. Tier 2 cities are picking up, but the aim should be that we go deep inside where every human being has got one mouth and that gives them energy, health, healthy mouth keeps healthy body. So we have to reach down to the Adivasis or to the area where dentists can't reach. There are no dental colleges. At this moment, well, Ayushman, whatever they have, they give 5 lakhs for oral health issues. They can give 1% for dentistry, and you see that a lot of people can go to dentist at 500 rupees a year, and they can save their teeth and keep their mouth healthy. And if this type of patient go to dentist, what is the difficulty for dentists? I know there are 26,315 dentists pass every year. Are you scared? Are dentists scared of so many dentists coming out? A lot of people are, but I think they shouldn't. The reason being, if every human being needs the dentist, where is the dearth of patients? If you say gynecology, 50% population is gone. Cardiologists, only those who get heart problem. Pediatricians, but dentists, small child has to go to a dentist. If there is a problem, if there is no problem, maintenance, fluoride application, sealants, etc. Elderly has to go to a dentist at least for scaling, polishing, and maintenance of oral hygiene. So काम तो बहुत है. There is a lot of work we have. So there is no difficulty for dentists, but difficulty for dentists is that overnight they want to do implant or become an aesthetic dentist or a TMG specialist. Friends, a child is born, he doesn't run immediately. He's born, he first rolls, then he crawls, then he start walking with the support, then he walks on his own, then he starts sprinting, and then he runs, and then he does marathon. Same thing after graduation. You have to learn by observing somebody. You should have a mentor to hold the hand and do your practice. Then you slowly ask and learn and learn and learn, and then become an expert dentist. You can't become overnight an expert dentist. There are a lot of postgraduates. After postgraduate, they become state teachers teaching young dentists. And young dentists listen to them. But you have to be very, very selective about what you do in life. Do you need money when you first 5 years of practice? No. There are your parents or your in-laws or anybody can give you roti kapda makan. So first 5 years, learn, then you earn. But today everybody wants to earn and put on social media. And after earning, they want to travel abroad for holidays. When do you need money? You need money when you increase your family. So you have to go step by step. I can give you only one example. If you do scaling polishing, I usually ask which is the branch of dentistry gives you more money, and they say implant, prosthesis, aesthetics, this, that. I said, no, scaling polishing. Initial years of your practice. Scaling polishing, no complication, no investment. If the patient, you got 500 rupees, you got 10 patients, 5,000 multiplied by 25, 75,000, expenses is 15, 20,000, 50,000 is net profit. But I want to do implant. So I asked them, will you do implant in your mother's mouth? They said, no. Then why you want to do implant in somebody else's mother's mouth? No. You can't do that. What you can do in your family member's mouth, do that first in the patient's mouth. If you can't do it, wait. But that doesn't mean your clinic should not do all the things what is necessary for patient. Yes, you call experts. There's so many MDS graduates and senior doctors who can help you out in doing it. So I have multidisciplinary practice. The difficulty is that I want to become king overnight. It doesn't happen. And then when you start your practice, you invest a lot of money in interior of the clinic rather than on dental chair. And once you have 5-10 years of practice, you do a lot of technology. So what is technology today? High technology. I know there are 40 dentists from Mumbai itself have gone to Germany. There's a big trade show going on. It just happened in Germany, IDS. Just finished last week. They've gone there. They had gone there. Why? Higher technology. Let me tell you, friends, higher technology in Western countries doesn't mean that higher technology has to come down to our country. I was observing one implantologist in Germany, Baden-Baden. She did implant and suddenly she realized that she required bone graft and membrane, etc. She did fat, they did it. So I quietly asked outside, I went outside and asked secretary, did you give her a budget of grafting material, etc.? She said, no, insurance pays. So friends, when you invest $100,000, they know how to calculate ROI, return on investment. And that ROI is very important for us to calculate in India. We never allow, one should not allow foreigners to talk about marketing in our country, because marketing is first you have to understand the consumer. That is your patients. So marketing in Mumbai, where I stay, and marketing in Delhi and marketing in Jaipur or Goa or maybe Kerala is different. So it depends on the intelligence and attitude of the patients. So do you need this highest technology in dentistry? Yes and no. Yes, if it is beneficial for patient. No, if it is not beneficial for patient, but is beneficial for you or to your technicians. You charge more when you got higher technology. You know why? For example, I'll give you example, a simple example. A laser. Take laser. I was talking laser, I bought laser. I worked on laser in 94, 95. First time I went to Israel, got laser. That time I was just calculating, if I take incision or do anything with laser, my charges is 250 rupees. Where I take an incision with blade, my charges were 50 rupees. But profit for me in 250 rupees was the same as 50 rupees. Why? because other money go for the machinery. So high technology is something we should always see the benefit. Is it beneficial to my patient? Yes, jump into it. No, wait. You know why? Because if anatomy, physiology of the human pathology has not changed, what is higher technology is going to do? It should be easy, fast, painless, and also be better. So technology like CAD-CAM technology, very good for fitting of the restoration. Aesthetics, well, aesthetics, artists only with the hands. If you do any artwork with pressing, in machinery, it becomes a print of the art. No artist, I always say that if no two human faces are same, no dentition is the same. So when you do something in the patient's mouth, is your art. So dentistry is art and science. Do not take loan and invest in technology if that is not going to give you money back. Do not fall prey to, what do you say, industry driven dentistry. In a sense, oh, or peer pressure. अरे यार मेरे दोस्त के पास ये है तो मेरे पास भी चाहिए. No. Marketing is only done how good work you do in the patient's mouth, how long that work stays, and how perfect that work is. Because dentistry is not aesthetics only. Of course, we say dentistry is aesthetic because anything you do in the mouth has to be look good. You can't tell appendix operation to be done aesthetically. Just tell general surgeon to do aesthetically. You can't do that. And the last and the most important aspect, I was talking of technology and expenses. We, the dentists, are blamed that we are expensive. We are not expensive. We are value for money. Few days back, I was having a sort of a discussion with a medical doctor. I said, you do appendix operation, you say my charges are 60,000, but the bill comes 1,50,000, and then you say, 90,000 is for operation theater, sterilization, this, that, ward boy, bed, etc. And we, the dentists all over the world, are fools because we give crown 5,000, 10,000, 15,000, all package. No. You should always tell 50%. If my crown charges are 1,000 rupees, I say 10,000 rupees, I say 5,000. But the bill comes 10,000, then I explain to them, like hospital, my technician charges, my impression material, my provisional, my cement, my burr, my boy standing next to do, and above all, my chair. Now, if your chair is costing 2.5 lakhs of rupees, is of general ward. If your chair is costing, and a high technology chair which is costing 6 lakhs of rupees, is deluxe ward. If your chair is costing 10, 12 lakhs of rupees, is a super deluxe ward. So your charges have to go high. It's not necessary that you should buy super deluxe chair immediately, but you should at least have chair which can do a fast job and invest more on the chair than on interior. And as you grow higher and higher, you should not only increase the charges. The charges depends on the quality of the patient come to you. So friends, the quality has to change so that your practice go high. So on Oral Health Day, I want to tell public at large that maintenance is very easy. Brush once a day, once at night, floss, etc. Visit a dentist every 6 months for maintenance as you send your car for servicing, service your mouth. For dentists, do what you can do in your family member's mouth or get it done from the specialist. Let me tell you, in my clinic, I got endodontist, implantologist, and a general dentist. My daughter is also dentist. I got my work done from them. Filling by my daughter, third molar extraction by a big senior associate, implant by implantologist in my clinic, and root canal by root canal specialist. That gives the confidence to the patient that, everything is done in this clinic. So be fair to your patients. And last and most thing, I can only tell to the dentist, first to the patient, that oral health, all your teeth should go with you without any cavity. If you can maintain that, nothing like it, your general health will be the best. And for dentists, always see the benefit of the patient first. He will see your benefit. Thank you very much. See that your patients are proud of their mouth. You will be responsible if they are proud of their mouth. And you should be also proud of your mouth that, yes, I did the best job. in that patient's mouth. Thank you very much. Enjoy World Oral Health Day. Actually, I should say that we have got birthday, anniversary day that come once in a year. But I think Oral Health Day should be every day because you brush every day and night. So Oral Health, World Oral Health Day we celebrate today on 20th, but it should be tell your patient that every day is a Oral Health Day. Thank you very much.
Welcome to our first panel discussion for today on back to basics, a key to good oral hygiene. In this panel, we will be discussing the importance of maintaining good oral hygiene practices and how going back to the basics can help prevent common oral health problems. I would like to commence this session by introducing our eminent speakers for this discussion. I welcome Dr. Sharon Quaco Diaz, HOD and consultant, dental medicine, Manipal Hospital, Old Airport Road. Welcome, Dr. Sharon.
Hi, I'm so happy to be here. Thank you. And I think this is a wonderful idea speaking on, basic oral health. I think it's a great idea and a great thing that you guys have done.
I welcome Dr. Ajay Kakkad, CEO, Byton. Welcome, Dr. Kakkad.
Hello, hi. Glad to be here and discuss whatever is necessary for oral hygiene. Good focus.
I welcome Dr. Shifa Shamsuddin, founder and director, We Little. Welcome, Dr. Shifa.
Thank you very much, Dr. Ritika. Hello, all.
I welcome Dr. Sovik Singha, consultant, dental and maxillofacial surgery, Care Hospitals, Bhubaneswar. Along with
So,
sharing his views, Dr. Shovik will also be moderating this panel for us today. Welcome, Dr. Sovik.
thank you. A very good morning to one and all. And myself, Dr. Sovik Singh, a consultant maxillofacial surgeon and medical legal advisor. So today we have an amazing panel on the topic back to basics, a key to good oral hygiene. Thank you, one and all.
Yes, so over to you, Dr. Sovik.
Yeah, thank you. Thank you, Dr. Ritika. So we'll start our today's discussion. So very good morning, Dr. Ajay sir, Ajay Kakkar sir.
Hi.
So hi. So we'll start with you only. So I want to we want to hear from you. What is the current scenario of oral health in India, and what and it comparison with the Western countries? How you see that?
Uh, well, that's a tough one because we really don't have extensive data in India being such a huge country. It's equal to half of Europe, possibly, which would have about 18, 20 countries in the same land area. And it's not that it's just the land which is big, but we also have so many different variety of cultures from the
Yeah.
length and breadth of the country everywhere. So it's extremely difficult, first of all, to extrapolate anything, let's say, done in Karnataka to Jammu. You cannot really extrapolate it. But going on the basis of whatever empirical evidence, general information available from having lectured all around the country, spoken to dentists everywhere, well, definitely there is a increased awareness of dental hygiene, dental health, and more people are trying to at least get to a dentist. But that's all still happening at the maybe the middle class and the upper middle class levels, where they are focusing a little on the dental health. We still face the major problem which our country is constantly facing for so many years, and that's so many people below the poverty line. We just can't afford to focus on dental health. They rather live without a tooth than spend money on getting a tooth replaced, something like that. So, yes, there is an improvement for sure. I remember doing one study about 20 years back from under with the ISP, and we had support from a few corporate companies. And we managed to check data on at least the periodontal health across 24 cities, which was the widest spread of any common study done. And in that study, we found that the incidence of periodontal disease is marginally higher than, let's say, Sri Lanka, where there are some European studies which have been done in the past. But compared to the absolute, let's say, Sweden or the Scandinavian countries or USA, no, we are still a long way off. Like scaling once in 6 months over there, even once in a year scaling hardly exists. Control of caries hardly exists. So we come in India, we come to a patient comes to a dentist when they have a problem, not for
Yeah,
maintenance as yet. We need to move to the era of where the patient comes for maintenance.
yeah.
Okay? Yes.
So yeah, just what Saras told, I am summarizing that thing. So basically, the lag part is in prophylactic treatment. Here we in India, people comes for direct treatment, for the pain part, but they don't do like prophylactic part, like fluoridation, oral prophylaxis, spit fissure sealant. Like these things are not doesn't exist. Also, some international schools and some schools are introducing, but that not in not for the common people. And the another thing what Saras told, that it bit expensive also. So yeah, yeah. So the actually the thing is, I am quoting one thing, that dentist is not expensive, but the neglect is expensive. Like we don't do
Absolutely.
filling, we go to root canal. We don't do root canal, then we go to Dr. Sharan
Correct.
for implants. So it the charges increases. So that is the thing, we have to concentrate more on the prophylactic part. We have to encourage people. We have, like the other our associations or the councils, they should look into like how we should keep this thing into the mind of a common people, like in schools, colleges, in like corporates. This thing we should introduce actually. So thank you very much, sir. So we'll move to the next question. Uh, so, Dr. Shifa, good morning.
Hey,
So,
good morning.
yeah, good morning. So, what are some of the basic practices that essentially we should do for to maintain our good oral hygiene? How you see
Um,
that?
okay. So, as Dr. Ajay was saying, that our country is far behind in terms of prevention. So, being the founder of India's first preventive pediatric dentistry, we run a chain of clinics which is focused on prevention. The huge challenge that we faced in the last decade is that, to get to the concept of prevention, right? So, and it starts from infancy, even before the tooth erupts. So, the oral hygiene is mostly considered regarding teeth and maximum towards gums. But little knowledge do we have that the mouth is the opening to the body, the mouth is the opening to the gut health. And gut health is highly regarded for general health, emotional well being. Gut brain axis is very important for the overall synchronization for the body, and it all starts with mouth. However, this level of understanding is very, very less right now. So going back to what is the first basics is, on an overall general population, to get your first dental checkup by the time the first tooth erupts, or at least by the first year, before celebrating the first birthday, is what is considered practically possible right now. However, the first step of prevention starts with breastfeeding, right? If you look at the majority of studies and evolution of humans, you can see that dental cavities or caries or gum diseases or crooked teeth is chronic, non-communicable, lifestyle induced diseases. These are all hardly genetics. It's based on our day-to-day practices. It's our lifestyle that has changed. So if you go back to history, ever since industrialization of food happened, right? That's when the load of dental diseases increased. And ever since industrialization of breastfeeding happened, so going back to the Second World War, when formulas were introduced to help infants that were separated from mothers, and infants who were not getting wet nursing or another mother to feed them were put on formulas. And the load is what we are seeing now. If you go back generations before, a lot of non-communicable chronic lifestyle diseases like cardiovascular diseases or dental caries um, uh, or hormone related diseases like diabetes were all in at the age group of 90 plus. That became 70, that became 50, and then right now, by 30 years we're getting this. And if you go back to see the history of why this is happening, it's predominantly when industrialization of breastfeeding happened, industrialization of food happened. So being a prevention focused practitioner, what I would recommend to all the practitioners is to ensure that breastfeeding is established as the first step of prevention. And of course, first dental visit at least by the age of 1, or earlier, as soon as 6 months, when the tooth starts erupting, would make a good base for a healthy, futuristic, overall well-being of the child.
Yeah. Thank you, ma'am. As you have told that our oral hygiene is the mirror to our general health. So, how do you consult your patients? Like, how do you make them understand? Like in our clinics, what we are facing, that ये तो दूध के दांत है तो चले जाएंगे, इस पे करना ही क्यों है? तो दैट वी आर फेसिंग इन डे टू डे लाइफ कि ये तो जाना ही है, इस पे इसके पीछे क्यों, व्हाई विल लाइक व्हाई टू सेव दैट टूथ, हाउ यू विल कंसल्ट दैट थिंग?
So basically, it's education. When it comes to prevention practice, we the doing is very less. That is, the intraoral work is very less, and the educating and counseling is a lot. So that is
Yeah.
where we educate them that this particular set of teeth or mouth is there. Inside the mouth is there for a purpose, for transition. It is not temporary set of teeth, right? So it is there in for purpose. And if this is not maintained, definitely the disease load in permanent teeth is going to spread. So the easiest way that we explain is to put a video of how the tooth eruption chart works,
Yeah,
right?
yeah.
The common misunderstanding is that all the teeth falls off overnight. That doesn't happen. So there is a transition between age 5 and 13. The milk tooth and the permanent tooth coexist inside the mouth. And an
Yeah.
education how, for example, we're looking at cavities as specifically as the disease, through the biofilm, through saliva, can spread from teeth to teeth, would be a good education. And how the disease load goes inside a tooth and affects the permanent teeth bud that is below the teeth is also a good example. However, this was there few years before. Right now, millennial parents that are coming in, who has experienced this diseases by themselves, most of the parents who walk in have had a painful dental exposure, have had root canals done, have got teeth pulled out and braces fixed. So they're very aware the load of the
Yeah.
treatment as such, not the disease. And they're so much aware that they don't want to prevent this for their children. So the
Yeah.
millennial parents that are walking in are much specifically prevention oriented. Especially we having infants like at 3 months and 2 months, wherein the parents walk in telling, I can see the lower jaw's gone inside,
Yeah.
right? And we all know that the textbook says a little bit of retrognathia in primary jaws is
Dentition. Yeah.
considered normal. Now this
Yeah.
is a huge myth that we've been believing. It's common now. So
Yeah.
just like how wisdom tooth extraction has become common now, but it's not normal. Retrognathia of lower jaw is common now because of industrialization of food, but it's not normal, right? So a mild retrognathia at infancy stage, even before the tooth erupts, itself is an indication that these child will have disease load when they grow up. And we're having parents at 2 months and 3 months walk in, do their bit of research and say, okay, I can see the jaw is behind. How is
Yeah.
that we can help? So that level of knowledge right now in the social media era, in the technology era, it is there. However, there is a certain amount of population that is still not aware, where I think prevention, focus, counseling, and education plays a major role.
Yeah, thank you, ma'am. I want to just add that school dental health program we should introduce more and more to educate the parents and the school-going childrens also, because the most of the patients we see they are MDs from Google University, so so we have to they are coming with the treatment plan also. Say they are don't tell the chief complaint, they tell the treatment, so we should make the chief complaint according to that. So that is the thing. So the mainly awareness is required, what madam has told. So thank you,
I
ma'am.
think Dr. Ajay wants to add something here.
Yeah, please. Sir, your mic is off, I think.
No, no, no. My mic is on.
Yeah.
My mic is on. Am I audible?
Yes, sir, please tell.
Well, I'm totally in agreement with whatever Dr. Shifa said about how to manage the child, how to manage the patient at a very young age, and how to counsel the parents. I'm in total agreement with all that. But I'm in total disagreement by putting the blame on what is called as industrial revolution. We tend to always say that, oh, the cardiac problem was not existing in the 1800s. In the 1800s, we did not know that there is something called cardiac disease. We have absolutely no data to say that incidence of cardiac disease, this is just an example, that incidence of cardiac disease has increased because of the modern life and the pressure and the tension. No, 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 no. We have no idea of the amount of cardiac disease that existed in, let's say, 1700 or when the industrial revolution started. No, we don't know. So we cannot just put the blame on a bad lifestyle, on industrialization, that we should be back to nature. No, that is not right. We could go back another 100 years, 1600, 1500, and we have still lesser and lesser and lesser data. So we cannot go on just grandmother's stories. I totally agree with her in how we should approach the problem today. Yes, we have got much more awareness. Like even in my own dental career, when I started off, I'm an absolute computer person. I'm one of the first people in this country to have an email account in dentist, to start a website for dentists. But how much of information exchange was possible in 1990 when I was doing my practice? To get anything, I had to write a letter to Europe or America and get a letter back, which would take about a couple of weeks. Today, it is done in a couple of minutes with technology. So, our information is much higher than before, much more than before. And that's what makes us tend to say, oh, there is so much of disease. That disease was always there. We didn't know about it. So we have to be very careful when we start attributing the blame to so many things which are not really tangible or scientifically proven. Again, I'm reiterating, I agree with the measures that she has told on what we should do, getting the child in when the first tooth comes out, counseling, breastfeeding, which is a very natural thing and should be done. So, all that is good. But we should be a little cautious when we just blame everything in modern lifestyle. No, 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 no. We can't do that.
So this is backed up by database, a long study of anthropology, and these are written in my blogs, done by Dr. Daniel, which is taken over by Dr. Kevin, wherein anthropologically they went back, and the textbook and the research can be found as Evolution of Human Head, and
Yeah.
it's been
Yeah.
proven that narrow jaws and crooked teeth are of industrialized human, wherein anthropologically these studies have seen that prehistoric human, before industrialization of food took place, hardly had micrognathia or high arch palate or narrow jaw issues and cavity issues. Especially if you look at the existence of third premolar, it started happening after the jaws have started shrinking in the process of human evolution. Now, wisdom teeth is a modern era. It's there for probably the last century, but before that, the wisdom teeth were erupting in mouth. So this is backed up by research by Dr. Daniel and Dr. Kevin.
Yes.
And the research subject is also published as a textbook, and it is called as
Yes.
Evolution of Human
I,
Head.
I, I,
And this has been published, and it not just talks about human head or head and neck and maxillofacial issues, but it also goes back to the history of anthropological studies about non communicable chronic lifestyle induced diseases.
Yeah, well, I've also gone through that, and we are not getting into debate into it. I can punch about 50 holes in that whole document that you mentioned. It is an extrapolation of data which is not correctly done, but we're not getting into that debate because that's on the agenda for today. So we'll keep it for some other time. It would be a very interesting thing to discuss and debate, and how to apply logic into science. There are a lot of things which are missed out in that entire anthropological data, but we're not getting into that. So please continue, Souvik.
Yeah. So thank you, Dr. Shifa and Dr. Ajay, for summing up the thing. So now my next question is, how flossing and mouthwash play the game in maintaining good oral hygiene. I want to ask to Dr. Sharon.
Hi.
Hi, hi, ma'am.
So, as Dr. Kakkar had mentioned, this flossing is a upper middle class or on the upper society problem or practice, because it is hard to get people to brush in our country. But those who are able to get them to brush, it is wonderful if we can go to the next step. Because I personally feel that your brushing just takes out dirt from three surfaces: the outer surface, the inner surface, and the biting surface, which are usually the most easy surfaces to keep clean. The surface that matters is the surface in between the teeth. And for that, we need to teach our patients to floss because of the soft core, the area in between the teeth, which cause gum disease when food is left behind, or you can have caries that develop. Patients can develop bad breath, or you can return to your meeting after lunch with spinach in between your teeth. So basically, it's a great practice to teach our patients, and I think there's a lot of health benefits to that.
Yeah,
About mouthwashes, personally, over the years of having done dentistry, I am not a big fan of mouthwashes. I feel that mouthwashes should be given only when necessary, when needed, medicated or needed. More often than not, I prescribe warm saline rinses to my patients, especially after implants, oral surgical procedures, or anything of that sort. I feel that I would like to give medicated, antimicrobial mouthwashes like chlorhexidine post gingival surgery, or even in patients who have a huge tendency towards gum disease. In those people, I would like to prescribe, and I do prescribe. And recently, there is hyaluronic acid, which is introduced in mouthwash, and they say they claim that it gives a better healing. So I have also started prescribing those. Desensitizing mouthwashes is something I prescribe after scaling, which is a large amount of tartar that is being removed, and I expect some degree of sensitivity. High fluoride is something I give to my orthodontic patients, or young adults or children who have a high tendency of caries. But I'd like to say that I don't think mouthwash can be a substitute for brushing, and people should know that. And it could be an adjunct. And it's like akin to saying, I don't need to bathe, I can just put deodorant and I'm fine. So a lot of people take it as a quick fix, but I think that's not a good idea. They have to be told that you need to brush twice, and then if you need to use a mouthwash, it has to be for the right reasons. Long-term use of mouthwashes with alcohol, I have seen, have caused problems. People have burning mouths, and they have loss of taste, dry mouth, and all such things. So I do not recommend them to use mouthwashes on a regular basis, only when it is prescribed by the dentist. So that's my take on mouthwashes.
yeah, ma'am. Just I want to ask one thing. There are
Sure.
like some dentists prefer to ask. They ask to do flossing first, then brushing, and some people ask first to do brushing, then flossing. How you see that? What is your sequence? How you guide patients?
See, honestly, I don't think it's important, but I would think logically, if you brush, you remove all something that's large in your mouth, large particles, and then you can move to removing the smaller things that may be present between the teeth. So I would say probably brush first and then floss.
Then, and ma'am, what about the essential oil mouthwash, like regular for regular mouthwashes people are using?
So as I said, I do not recommend regular
Okay.
mouthwashes. I don't think it's necessary. I think if you
Okay.
brush well and floss well, you don't need that extra mouthwash at all. You know,
Okay.
I think just rinsing your mouth with regular water should be good enough.
And in toothbrush, like there is a shift, like for the IT people, they are shifting towards electronic brush and all. How do you see that? Like, you prefer, or
I'm
you
sorry,
don't?
your voice broke up.
Yeah, electronic toothbrush. There is a shift for like IT people who have been there in US or like other countries. They have seen and they are using, and they have started asking people to follow that electronic toothbrushes. So how you?
So So I feel electronic toothbrushes is like AC or fan, especially for the computer age people. I think both are good enough, and if you use them well, it's fine. Electronic toothbrushes, I think, are a great use in the geriatric population, especially those who have poor manual dexterity, who have
Yeah,
arthritis, who have issues like that, and that can be a great aid for them. Or for those who have caregivers who are doing it
yeah,
for them, like a
yeah,
nurse who's doing it for them, or daughter, son, or whoever who's taking care. It's great for them, and
for
sometimes
basically
also
for
in
the
children.
physically compromised people. Yeah,
Correct.
yeah,
In physically compromised, and on people who have poor manual dexterity for whatever reason it may be. But for
yeah,
the others, I just think it's a luxury. I don't
yeah.
see a great
We are becoming
advantage or need.
lazy, more and more lazy. Yeah, ma'am.
Probably you
Thank
could
you.
say that. Yeah.
Yeah.
You're welcome.
So we'll go to Dr. Ajay for the what are the some misconception about the oral hygiene that people should be aware of? Myths and misconceptions.
Well, myth and misconception. The biggest myth is that getting your teeth cleaned makes your teeth loose. That's the most
Most common.
common myth that prevails all over India, and nothing could be further from the truth.
Yeah.
Okay, in some places it may happen that there is a huge amount of bone loss, and there's so much of calculus there that the teeth somehow are not totally mobile because of being held by the huge amounts of calculus there. And you remove the calculus, and each tooth can be felt as mobile. But that's such a uncommon situation, and it happens with one person, and that person tells 100 people, and 100 tell another 10,000 people, and the myth prevails. So it's an absolute 100% myth that scaling causes loosening of the teeth. No, very, very wrong. That's not a correct myth. A second myth which tends to prevail, even today, I get patients who come and somehow, I don't know from where it originated. I've tried my best to find out, and I can find no connection that working on the teeth or cleaning the teeth and the gums causes eye problems.
Yeah.
That's a, it's a weird myth.
Extraction of
And I
upper
see
teeth.
that, yeah, and I,
Well,
especially when you do the upper teeth, and I see that happening more in tier two cities
yeah.
where people talk about such things. I get a lot of patients from all over India, and when they come from these smaller places, these are the first two questions that generally a patient asks me when they are referred for any perio problem, which are total absolute myths. And I just brush it aside and very emphatically tell my patients that absolutely no connection and totally wrong. There's not even the slightest amount of truth in these two myths. I don't think there's any other. The third myth is it's not a myth, but it's a complaint of many patients, and it's justified also that when I get my cleaning done, my teeth become sensitive. That does happen, and it happens all the more when scaling is not done in the most efficient way. Unfortunately, today also 90% of dentists use a ultrasonic scaler in an incorrect fashion. They buy the scaler, they get four tips with it, and then they live it with the four tips and the scaler for a lifetime. The life of the tip is just 4 months, and it lasts for 40 years. So that tip is bound to give sensitivity because it is gouging out parts of the enamel, and microscopic damage to the tooth is happening. that is bound to increase sensitivity. But that is more of an education required for the dental professional rather than the common person. And I also still see, unfortunately, I still see a lot of dentists removing tough to remove calculus with an air rotor diamond burr. Absolutely, absolutely incorrect. In fact, I've
Yes.
just finished a series of 30 lectures all over the country. I've lectured in 30 cities in the last 3 months. And at all the places, when there's a question answer happening afterwards, average attendance 70, 80 dentists in each lecture. Some of them ask, sir, is it okay to use? They don't say, but then I understand immediately that they are doing it, but they don't want to admit it. Okay to use the polishing burr
Yeah.
after scaling, and no, 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 you can't do that. You can't put an air rotor to remove calculus. So
Yeah.
these are the points that I would like to stress on.
So after scaling, do you use peroxide or like for the,
Hydrogen peroxide,
yeah, yeah, in
no way,
dilution?
no
Yeah.
way, no way, not at all. And I don't recommend it to be used by anybody. We don't put peroxide in the patient's mouth anymore.
Yeah,
No
yeah.
way. No.
And sir, what is the role of sonic scaler?
100% role. You should not do dentistry if you don't have an ultrasonic scaler.
Sonic, sir. Normal sonic
The
scalars.
sonic scaler works at 5. The sonic scaler works at about 10% the efficiency of an ultrasonic scaler.
Ultrasonic scalar. Yeah, that is why.
So
Like,
why use it? So why use it? It's 10% of the efficiency. And today the Chinese people, today means in the last 15 years or so, the Chinese people have made remarkable copies of the best scaler in the world, that's the Satellite. I'm not doing a company promotion. Satellite doesn't exist also anymore. They have called it Action now. But they made the best ever ultrasonic scaler.
scale.
And the Chinese people are experts at copying. They made
Yeah.
a
In low cost.
remarkable clone at 20% of the cost. So
Cost.
today
Yeah.
you can afford to buy a scaler and throw it away after 2 years.
Yeah.
My original three ultrasonic Action scalers, which I purchased in sequentially in 1988, 1991, and 1994. Two of them are still working. The third one had to be disposed of because there was a mistake made by my chairside assistant, and they left the water on, and the whole tray got filled up with water, and it shorted the entire system. But otherwise, my two ultrasonic sailors, which are more than 25 years old from Action, still function as effectively. Of course, we change scalar tips every 4 months.
Yeah.
That's
Thank
critical.
you.
That's
Yeah.
very critical.
Yeah. Thank you, sir. So we'll go to the next question to Dr. Shifa. Uh, yeah. So how diet and lifestyle choices are gives impact on your oral health?
Yeah. So, as I was suggesting earlier, if you look at the prehistoric humans, the diet included a balanced diet of non processed food, which included a lot of natural fibers that required wear and tear, and less of easily available processed sugars. Right now, even the carbohydrates are broken down and available as easy sugars, so that the bacteria can act on them easily. This is the first thing that we see a lot. And if you go to why this is connected to head and neck or oral cavity issues, is that with the head and neck, diet plays a major role, like exercise, right? Chewing the fibers, tearing, biting, and removing. All this plays a huge role in direction of the craniofacial muscular component and the jaw growth. So the jaw growth to be an anterior forward placement, was happening predominantly. So if you look at the prehistoric humans, or humans before technology, or humans before industrialization, the jaw growth was more forward and wider. And if you look at why this is happening, is because of availability of complex carbohydrates through the process of chewing, tearing, churning, and grinding, which is very, very low now. Like, especially if you look at the pediatric population, the children from the breastfeeding are started with pureed food and continue to have pureed food for a very long time. And a lot of the children right now have non-mindful eating. So when we say non-mindful eating, it's predominantly in front of a gadget or TV,
Yeah.
wherein the child forgets to chew and eat. And if you look at most of the children, the food load, the carbohydrate load is like they pouch it on the buccal vestibules of either of the jaws and leave it there. And this causes an increase in plaque pH because of the load. So ideally, if you look at the biomechanism of eating, we chew, eat, swallow, and there the tongue and the saliva cleanses, and you have a clean oral cavity. But when this process is not happening, you are there pouching the food, sitting in front of TV, putting the carbohydrates to just sog and increasing the acidic level of pH. The biofilms content itself changes, right? So it is so much of availability for the bacteria, the microorganisms to grow, and the biofilm increases. Now, mindful eating is the key, is the success for jaw growth. Now, that is one load. The second load now is, if you look at nature, or if you look at the process of how earlier the child growth was, breastfeeding was considered normal, right? Up till a long age. So as you go back, if you can see that a school going child would also breastfeed and a newborn would also be breastfeeding. But there's a huge taboo now. A lot of them, by the age of 6 months, stop extended breastfeeding. However, even the WHO recommends exclusive breastfeeding till 6 months of age. And after 6 months, age appropriate solids, and extended breastfeeding a minimum of 2 years, right? So this level of breastfeeding is not only required for nutritional benefits, but the process of breastfeeding itself is like a functionality. So the breast inside the mouth is the first functional appliance that the child can have. So the process of sucking, chewing, swallowing the breast, moving all the muscles and tongue, it's like an exercise for the head and neck. What it does is stimulation of the jaw growth to a more um, optimal position, to a forward, a wider position. So now these two major modifications that's happened in the modern world, is taken a huge load on the oral diseases, right? So if you look at a community practice as such, if you want to look at the umbrella of community practice, the major way of reducing this disease is to spread awareness of exclusive extended breastfeeding, number one. Secondly, increasing a balanced diet of adding more fibers and less of processed or grounded or uh, swallowable food for children. And the third important thing would be mindful eating, non-distracted, having a meal time, sitting and chewing and eating. So these are my opinions, Dr. Shauvik.
Yeah, yeah. Thank you. Thank you, ma'am. As you told that about the non-mindful eating, and the I'm saying that parents are also like introducing these things to like to reduce the effort. Like they are giving mobiles to the children. They are putting cartoons on that, and they are also busy in mobiles. So that a busy lifestyle, and everyone is like. Doing this thing, even we are also doing non-mindful eating during TV or talking in the phone. That is one thing. And another thing, you have told that the use and disuse of organ, that is the thing. We are using more processed food, shake, milkshake, everything. We are like, as because of the time and the thing, we don't want to
And
chew.
even if you look at the infants, the dal chawal or the sabji is like ground, mixie. They
Yeah,
just make it like a puree, and then there's only swallowing. There is no chewing and swallowing that is happening.
yeah, yeah, yeah. Thank you.
Souvik, I would like to add some experiences that I had. I'm in total agreement
Yes, sir.
with Shifa. 2 years
Yes,
of breastfeeding should be a must, an absolute
yes.
must. But something I was very interestingly observed. I've been to the US specifically 11 times in the last 24 years or something. And generally, it has been because some relative, friend, etc., 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 got a baby. So we have gone to see the baby after 8 months, 9 months, 10 months, whatever.
Yeah.
And even in my extended family here, there have been people who have had children, small babies have come in, and I would shout actually at my nieces and nephews that stop this kawa dekho. You stick something into the child's mouth, and you're taking a 2 hour process over feeding your baby, which is so wrong. And now then the latest thing came in, mobile पे कार्टून चालू है, and but माँ पीछे पीछे भाग रही है and is pushing food into the patient's into the
Yeah.
child's mouth. And we say that we learned all this from America. You know what I observed over there? Across the board, 90%, those children are sitting on a high chair. When they are eating, they are only eating, and they finish their meal in 20 minutes. And I jokingly I would say these American kids, even the Indians who are born in America, are howrats. They just want to eat. They are not seeing TV that time. They are not having a mobile that time. The mobile culture doesn't exist in America. In India, we are obsessed with the mobile. That culture doesn't exist in America. They come home and the mobile is shut off and kept away even by the parents. So those children eat much, much, much better than our Indian children here in the last 15 years of my personal observation. So we cannot just say, "Yeah, America se seek kya hai." Go and learn the right things from there. Don't pick up the wrong things from America. Like those children are lovely and they're eating and they're focusing on the eating. They're eating the proper thing. They are not seeing TV, they are not running after the child and finishing the meal in proper time. Unlike India, where our parents, as you rightly said, Souvik, don't have time themselves, so they put it on the mobile or the TV or something. And I totally agree with Shifa.
So we'll move forward to our last question to Dr. Our oral hygiene impact our overall health, and what are the long-term consequences neglecting the oral health?
Poor oral hygiene. Poor oral hygiene, that the
Yeah.
most important thing is uh, uh, the effect of the mouth on the body, the mouth body connection. So
Yeah.
poor oral hygiene, which gives rise to cavities, gum disease. I mean, you need to have a checkup done once in 6 months to make sure that things are not changing in the mouth. There are no ulcerations that are being developed in the mouth, which could be precancerous. There is no starting of any lesions of that kind. That is something that needs to be constantly looked into. And poor oral hygiene will give rise to gum disease with cavities, loss of teeth, and all of those things. How do these things affect the rest of the body? There are studies, and it is proven that what happens in your mouth doesn't stay in your mouth. It goes through the rest of your body and affects the rest of your body. And as Dr. Shifa had mentioned earlier, she said the gut and the gut health is so linked to your brain health, the way you think, the way you behave. So the mouth is the starting of the gut, and so that is so important. But we now know that it has effect on cardiovascular system, that it has effect in pregnant women who have gum disease, are known to have low birth weight babies. And there are, even during their pregnancies, they are affected by the fact that they have poor oral hygiene, by having gingival swellings, or their wisdom teeth get inflamed and then they need antibiotics, or they need to have procedure done by that at that time. So this definitely is a problem, and it's something that has to be turned around. So that's why your oral hygiene is most important. There are people who have skin ailments that are linked to oral problems, joint ailments that are linked to oral problems. We all know about bacteremia, the bacteria that enter the bloodstream through the mouth and circulate throughout the body. The most important, the king of problems is diabetes. We being the diabetic capital of the world, we see so much of gum disease in diabetics. And we have to keep counseling them to take great care of their teeth because it affects their overall health. The many of them have gum disease that itself increases the sugar and the dependence on the medication and the way the medication work on them, and it creates a vicious cycle which needs to be cut at some point. And the easy point is to have your teeth fixed, to have the gums fixed, to have them cleaned, to have them looked into, and to remove all infection from the mouth. So these are things that I would say will affect the whole body, and so it's important that oral hygiene is maintained.
So thank you, ma'am. Basically, yeah, sir, please.
So, I would just like to add one extension to this. Total agreement with Dr. Sharon in all that she said, 100% right. I would just like to share my experience over the last 4 years, where this dramatic concept which I learnt about, which has been used and tried and fine tuned in Hungary. It is called the Smileys concept. And last 4 years we have been treating, and now we have got about 80 dentists in India who have been trained in this and who are treating, believe it or not, the lower jaw causing, I just list out the diseases instantly, and which are remarkably turned around completely. Migraine, tinnitus, double vision problem in the eyes, TMJ problems, cervical spondylitis like pain, inability to turn the neck, inability to move the hand completely, upper backache, mid backache, lower backache, hip joint pain, unilateral knee joint pain, heel problems, chronic acidity, and unable to exert, too much of fatigue constantly. Trismus, snoring, thyroid problems. I've listed about 18 problems, all of which get magically, seemingly magically resolved when the jaw position is corrected. Since you're talking about the systemic connection, I had to
Yes.
tell you that this is totally 4 years back. I had no clue about this. It's only in the last 4 years that I learned about it, applied it, and I've been teaching it. And I'm fascinated with cases which come in every day. In fact, today morning, one case came in from one of the students, and remarkable and fascinating results. The whole concept is called the Smileys concept. Now go ahead. Sorry to interrupt.
Thank you. Thank you, sir. So basically, it's a two-way street. If you take care of our general health, it will give impact on your oral health, and if you take care of our oral health, it will give a better general health. So thank you, everyone. So it was an honor to have you on the panel, and we know your time is precious, and we are immensely grateful that you are able to carve out some time with us. Thank you for helping making this event a grand success, and we look forward to seeing you in future events.
Welcome to our second panel for today on early detection of oral cancer, joining efforts for better cure and care. In this panel, we will be discussing the importance of early detection in the treatment of oral and head and neck cancers and how doctors and patients can work together to achieve better outcomes. We will explore the latest advances in the early detection methods and treatment options, as well as the challenges that patients and doctors face in the diagnosis and treatment of oral and head and neck cancer. I would like to commence this session by introducing our eminent speakers for this discussion. I welcome Dr. Manish Tiwari, consultant, head and neck oncosurgeon, Kakino's Healthcare. Welcome, Dr. Tiwari.
Hello. Hi.
Dr. Paul Mathai, consultant facial plastic and oral cancer surgeon. Welcome, Dr. Mathai.
Hi, good morning. Thank you for having me.
Dr. P. Subramaniam Rao, consultant, ear, nose, and throat, Manipal Hospital, Airport Road. Welcome, Dr. Rao.
Good morning. Hi.
Dr. Sandeep Nayak, P. Senior Director of Surgical Oncology, Robotic and Laparoscopic Oncology, Fortis Cancer Institute, Bangalore, Professor and HOD of Minimal Access Surgical Oncology, Bangalore. He will join us in next 5 minutes. Dr. Avinash Chaitanya is consultant, head and neck surgical oncology, Care Hospital, High Tech City, Hyderabad. Welcome, Dr. Chaitanya.
Hi. Hi. Hi.
Along with sharing his views, he will also moderate the session for us today. Over to you, Dr. Chaitanya.
I welcome you all and thank you all for the opportunity. I would like to tell you about what oral cancer is. Everybody knows what oral cancer is and what its burden on our society is. The issue with oral cancer mainly is that even though the symptoms come very early, it'll start as an ulcer or it'll start with pain in the oral cavity, difficulty in swallowing, difficulty in speech. So many symptoms are there, but people ignore them. People present to us at a very late stage, and as you all know, as stage progresses, the outcomes will deteriorate and it will become very difficult for us to manage them. And after such a big surgery that we do, or some other treatments that we have to go through, and still the outcomes are bad, it is very difficult to explain to the patients about what is happening. So today we would like to discuss about what we can do as a doctor, as patients, that we can improve upon the outcomes of oral cancer, especially apart from other head and neck cancers, and what steps have been taken are the recent advancements in the diagnosis and treatment of early treatment and early detection of oral cancer. So I would like to start this session with know the incidence and prevalence of oral cancer and how is it different from a rural perspective and an urban perspective.
Right.
Over to you, Dr.
So,
Mani.
see, the incidence of oral cancers is like highest in the world. If you see in India, the oral cancers, it amounts for approximately 30% of all the cancers. And if you see cumulative risk for developing cancer in India, it is like 1 in 60. So one person out of 60 people can develop oral cancers. This is as per NCRP data 2020. And the problem is so severe that 75% of our patients, they report to us in late stages, like the disease has either spread to, like, from oral cavity to neck, or it has already had a distant metastasis. So 75% of cases we see in very late stages, and very few patients they come into early stages. So this is the magnitude of the issue. And if you see, like, we see approximately that are like I'm telling about registered cases, about 1 lakh cases per year, and 50% of these patients, they die within first year of diagnosis. So this is about the prevalence, you see. And when it comes to rural and urban regions, yes, there is a difference in oral cancers. The rural people, they have got more chances of developing oral cancers, and this can be attributed to a lot of factors, like rampant use of tobacco and alcohol, poor oral hygiene, and lack of screening facilities for early detection and all. So these things together, they contribute to more number of cases in rural areas than urban areas. Yeah, Avinash.
Those were some interesting and shocking statistics that you have told us, Dr. Manish. Although we know that India is kind of the tobacco capital, tobacco chewing capital, as you can call it, of the world, and Southeast Asia is having the highest number of tobacco chewers. we would also get to know about the incidence and prevalence is very high, as you say, especially at a higher stage. So we should know when to detect them early. So I would like to invite Dr. Sandeep to share his views upon what are the early signs and symptoms of head and neck cancers, especially oral cancers, if Dr. Sandeep is available. Dr. Subramanya Rao, can you take over that question? And I think Sir has joined. Hi, Dr. Sandeep. We lost you for a minute. Uh, can you please share your views
Yeah, now
upon
I
what are
can
the
hear
early...
you, but there is some network issue. I don't know. I'm not getting. There is getting interrupted a
Okay.
lot.
Are you okay now? Is it fine? Are you connected now? Dr. Sandeep, we are losing you again.
I think we should move ahead to other panelists. Once we get Dr. Sandeep's network going on, he can join back and we can ask the
Yeah.
questions. Yeah.
The same question I can repeat to him later on, and
Yes,
you
yes, you
can
can.
edit that and add it there later on.
Yes, you can do that.
Yeah. Okay. So now, considering we know about the early signs and symptoms that oral cancer presents with, can you, Dr. Paul, can you let us know what are the challenges that we face in diagnosing them at an early stage? Because we know that the symptoms are there, the signs are there, and but still the patients are getting diagnosed at a later stage. You must be seeing a lot of patients in early stages. How do you diagnose them?
Yeah, Dr. Avinash, thank you for that question. So I think Dr. Tiwari very clearly gave us some very important statistics that a lot of our patients present in the later stages of oral squamous cell carcinoma, making treatment very difficult and also leading to poor long-term prognosis for those cases. And
Yes.
the real challenges that we face primarily are number one, lack of awareness. Our patients are not aware as to what the signs and symptoms of oral cancer are. Okay, they are not even aware. A lot of them, at least a good number of our rural patients, may not really be aware of the bad effects of having tobacco and alcohol rampantly in the long term, right? Then apart from that, uh, in the early stages of oral cancer, the signs and symptoms are very similar to other conditions like just periodontal disease or oral ulcers. So it makes it very difficult to diagnose. So there's also a lack of awareness on the physician's part. We are talking about maybe our GPs, our general dentists who look at our patients on a day out on a more frequent basis, right? Even they aren't really taught to pick out and differentiate between an oral cancer in the very early stages compared to other oral conditions. Apart from that, like Dr. Tiwari said, majority of our cases present late, already having reaching to a size of more than 4 centimeters at T3, T4 levels, and with a positive nodal status. And of course, the most important thing is there's a lack of access to healthcare as well. Good healthcare facilities wherein the entire uh, process from diagnosis to treatment is streamlined, and the patient is able to get both the right kind of assistance from the right kind of doctor, but also monetary assistance, right?
Uh-huh.
And also support from NGOs as well, who support the patient and the family throughout the entire process. So if we were to if we were to address these challenges, the first thing we need to do is we need to increase awareness. We need to have public health campaigns to help patients understand what the signs and symptoms of oral cancer are. We need to have focused healthcare campaigns as well to target those populations and those demographics that are showing greater incidences of oral squamous cell carcinoma. We need to have regular screening protocols put into place. Our family doctors, our ENTs, our general dentists who are treating these patients and looking at these patients so much more commonly than us and at an earlier stage should also be made aware as to how to diagnose, take a history, do a proper examination of the mouth, the nose, the throat area, right? Diagnostic tests should be available, right? Even the advantage of having a CT scan in a rural a CT scan center, these kind of facilities in a rural area will help a lot in early diagnosis. Apart from that, patients should have good access to healthcare. The government should implement schemes to provide financial assistance. There should also be, social workers who would handhold the patient right from beginning to end, and also, help them understand the significance of what they are about to go through, and also help the family rally around the patient. Okay. So, and of course, last but not the least, on a clinical side, patients who are diagnosed with pre-malignant lesions, maybe these patients could be followed up uh, more regularly, more frequently. Efforts could be made to bring about tobacco cessation and reduce alcohol intake. So these are just some of the. So in summary, these are the challenges and these are the ways we can try and overcome them. It's not an easy task, but I can definitely see a lot of change happening in the last few years, and I think we are going to reach there one day.
Those were some extensive lists of things that you want from the government and NGOs. I know people are going towards a tobacco free and a cancer free zone, but it is still a very far distant milestone to reach. But now that Dr. Sandeep is here, I would like to ask him about what are the early signs and symptoms that a patient should look out for or a doctor should look out for uh, so that they can diagnose a early oral cancer rather than late. Especially as Dr. Paul was saying that most of the patients are getting diagnosed late, and everybody in a healthcare system or outside the healthcare system should be knowing how to diagnose oral cancer or at least guide them towards the correct path. So you should enlighten us about some of the early signs and symptoms of oral cancer. Dr. Sandeep.
Dr. Avinash, thank you. Sorry, my internet was very bad. I don't know whether it will sustain also or not because I'm inside the hospital, so there are some
Understand.
network issues in this place.
Understand.
So, I'll continue. I'll explain as long as my internet sustains. I'm using my mobile phone. So, as far as early signs of cancer are concerned, there are two clear aspects of it. One is the personal awareness among public and the awareness among the doctors, because there are 2 points in which we miss a patient or a patient misses the opportunity to diagnose cancer early. Once the person reaches a specialist, then it's a different ball game altogether. So
Yes.
it's all about bridging that gap from a personal awareness to a awareness among a doctor. So these are the two things. So what does how does an individual look for any signs of risk? Every month, it's oral cavity, mouth is a very easy thing to look. You stand in front of mirror, you can look at yourself in all areas. So stand in front of a mirror, look inside, and see for anything that was not there previously which has appeared today. It could be a red patch, it could be a white patch, it could be a wound, it could be some bleeding area. Anything that is new has to be evaluated. So that
Yes.
is the key message, because there is no way a common man, it is difficult for a specialist to diagnose and say this is cancer. You need a biopsy to prove it. So I don't expect a common man to do it.
Yes.
Then when it comes to a doctor, a special, any dentist or a general practitioner, a patient comes with a suspicious area, it is very important to have a element of doubt when you're evaluating. So
Of
here
course.
what matters is the duration of the symptom. So anything that has persisted for over 3 weeks needs to be seen with suspicion. It could be a nodule ulcer, anything which has persisted over 3 weeks has to be considered as suspicious and further evaluated. So evaluation, if the dentist is capable of doing it or a GP is capable of doing it, it is usually a biopsy which is indicated. A biopsy needs to be done whenever there is a suspicion, and then further evaluation has to be done. Now, what is our aim in early detection? Early detection is to catch a condition in a pre-malignant state. We are not looking to get a disease in malignancy. So, if our surveillance system is good enough, we should be able to catch the diseases in pre-malignant and treat them before they reach malignancy. It is possible in oral cavity. So
Yes.
that is our intention. So that is where we should be moving. So the idea is anything that is new in the oral cavity needs to be further evaluated in the right manner. So that is the message which should go today.
Very well said, sir. So, as sir is saying, it should be always a high degree of suspicion whenever there is an ulcer which is not healing for 3 weeks. Anything that is not there in the other person, if you are having, that itself is a thing that you should evaluate. And oral cavity is one of the easiest place to evaluate. Unlike what Dr. Paul was saying, that you need to have CT scans and those things, oral cancer, the easiest thing to examine, easiest thing to know, and once you get to know that there is something suspicious, you can always be referred to a higher center and get it treated. So, I would like to ask Dr. Subramania about what are the common misconceptions in oral cancer and how they can be corrected to improve the early detection of oral cancer and improve the cure rates.
As Dr. Sandeep Naik was saying, early detection is the most easiest way of identifying and treating. And I think, as he was saying, it is a very easy area to see and evaluate. Anyone can do it and can understand there is something abnormal. But there are a lot of misconceptions about the cancer of the oral cavity, which leads to a late diagnosis, which leads to a late assessment. So one of the most common, I think, is denial. I think what the patient say is, see, I don't know, I can't have cancer. None of people in my family have cancer. So I think that's one of the most common misconceptions, saying that since nobody else in my family has, I don't have. So why evaluate? I think it must be something else. Just leave it alone. So I think that is one of the most common. Then on the other side is that people say that I don't have. So cancer is caused by tobacco and alcohol. I have none of these habits. So why should I? I think this is something else. I think it will go on its own. So that is how it gets delayed. Then some of them may say that I don't use tobacco, but I use supari, and supari has been being used from generations to for all these generations. My parents, my grandparents, everyone has used it. I don't think supari can cause cancer. Then the newer trends like e-cigarettes, hookah. They say I have not smoked. I don't take this one, but I use this, and I don't think that causes cancer. So then there is some people who say that I have undergone blood tests. All the blood tests are normal. So I don't think I have cancer because the blood tests are normal. So there's still a lot of people who say that, of course, some of the cancers do have blood tests which can detect them, but I don't think any oral cancers have blood tests. But people are in denial, saying that yes, my blood tests are normal, so I don't think I have cancers. Then there is another misconception saying that no, I don't want to undergo biopsy. People say that the moment I undergo biopsy, there is a change in the tumor and it becomes faster growing. So these are some very common misconceptions which are there. Then on the other side, people say, "Oh, I think this is cancer," but people say that I have cancer does not have any cure. So why should I investigate now? I'm anyway going to die. Why should I investigate and go through the painful procedure? And they land when it becomes really intolerable, when it becomes really advanced. So these are some of the misconceptions which people have, which prevents early diagnosis and treatment.
And one more point I would like to add from Dr. Subramania is that some patients are afraid because they have already seen somebody go through that treatment, and then they are afraid that I have to go through surgery, I have to go through radiation. I don't want to go through.
There
Let's
is one
wait.
more.
Let's wait. Yeah,
The
please add.
social stigma. So if somebody has
Yes.
gone to a doctor for screening, oh, this person has gone to that doctor for screening, so there must be some problem this guy has. So people do not want to undergo that social stigma. So that
Yes.
is why they say, no, no, I don't want to go for any screening. So some of these things.
So basically, denial and fear, and of course, some people act over smart. So those things are the issues that we have in early detection, and those cause the diagnostic delay, as we call it, for oral cancer. So I would like to ask Dr. Manish about his views on what the lifestyle factors like smoking, alcohol, and poor oral hygiene have to do with causation of oral cancer. I would like you to turn your screen, sir.
Am I audible now, Avinash?
Yeah,
Am I audible?
yes, sir. Please start.
Am I audible, Avinash?
Yes, you are audible, sir.
Okay, so see the lifestyle factors like alcohol, tobacco, diet, and oral hygiene. All these factors do play a crucial role. People who consume tobacco, they are of course at elevated risk from if you compare them from normal public, and people who consume tobacco and alcohol together, they are at even higher risk of developing cancers. Coming to diet, people who consume diet less in fruits and vegetables, uh, I mean that is less antioxidants in their diet, they are at higher risk of developing cancer. And oral hygiene wise, if you see because of poor oral hygiene, there can be accumulation of harmful bacteria in mouth that can be inflammatory, and because of these chronic inflammations, there can be a chance of developing oral cancers. So to tackle all these things, to tackle these lifestyle related issues, it's very important to educate people, to educate masses about the ill effects of using tobacco. They should get into regular screening process. So like government of India itself have said that people who are above 30 year of age, they should get themselves screened for say breast, cervical cancers, and then oral cancers and these things. So these screening things has to be kept into mind, and people should also be made aware of proper hygiene practices. Okay, there are a lot of people in rural areas, they will use some tobacco containing some this thing, tooth powders. Many people use some mystery thing. So all these things together lead to these issues. So a good oral hygiene practice should also be educated. We at Karkinos, we have launched a technology backed platform, that is a Karkinos app, where we give risk assessment to the people. Like we people can enter various questions. There are some questions, people can answer those questions, and the app will ultimately tell them whether they are at elevated risk of developing any kind of cancer or not. So these kinds of technological innovations will also help people detecting these things. So we are trying to get these things to people, to download this app, the Karkinos app, and once they are detected of having any kind of cancer, we handhold these patients to get into further treatment phase and
You're not audible, sir. Okay, so now that we know that there are being some developments in the early detection of oral cancer, like what Dr. Manish was saying, some apps and always are there for us to diagnose. There have been certain NGOs who have been working towards developing these apps, and with the help of the social workers and the Anganwadi workers to diagnose and screen the rural population of the country. So I would like to ask Dr. Sandeep if there are any other newer technologies that have come up and what he has been using to diagnose oral cancer at an early stage or at any stage for that matter.
Uh, yeah, Dr. Avinash, as of now, as of date, the best technology is our mirror and humble eyes. What
Very
we
true, sir.
see, that is the best way. But yeah, so and a high degree of suspicion, that is the best tool that is available. But just like for example, for breast cancer and cervical cancer, the way the things have changed over the years, there are technologies which are trying to come into the field and use various ways to detect. One of the things which came early and which has been established is well scope, which
Yeah.
uses certain degrees of wavelengths of light, you and see how mucosa reflects that light and detect whether any area is suspicious.
The
Second,
malignancy.
in fact, sorry, yeah, any suspicious area, it does not tell you whether it's malignant or not. See, malignancy or not requires, or cancer or not requires a biopsy to prove. So uh, the the effort which is there in any screening program or anything which is to do with screening is to identify whom to screen or who needs further evaluation. That is the question now, because we are a
Yes.
country of a huge, or any population for that matter, because every person cannot reach a doctor, because it's
Yes.
not practically possible to reach a specialist and diagnose. So what is to be done always is to is that a patient should be, or person should be screened at community level. So how do we do that? So that is done using tools. So the tools include these, like well scope, and there is some other tool which has come, which is from a Trivandrum based company, Oral Scan or something like it's called, and that uses AI to detect any oral lesion.
Yes.
So when a person screens the oral cavity, or a nursing staff or a trained technician screens the oral cavity with that particular tool, it'll it'll give a scoring to it: low risk, medium risk, or high risk. So any patient in high risk will need an evaluation, further evaluation by an expert. It could be biopsy, just an examination. So that patient requires to go to a higher center. So that these are the technologies which are coming into the foray, and in fact, the biggest thing that is coming into the game is AI. It is same thing with lung cancer also. There are tools which are coming because they're all aerodigestive tract cancer and come under the same category. So there they're trying to analyze X-rays to see if X-ray themselves can be used for lung cancer. Same way for oral cavity, AI being used using the same light, that is, a blue light they are using to reflect and see whether it is these areas are suspicious or not. So that is something which is coming, and I think that's a promising technology because it simplifies things and lists out people who need further evaluation.
Yes. So a high risk population has to be identified first and they should be screened early, like people who are having tobacco habit or a smoking habit. If they are screened first, it is easier to extrapolate it towards a higher population. And also, I would say that Google is actually helping us because everybody who Googles, all symptoms lead to cancer, so that actually helps because they will,
Dr.
if they
Avinash,
have a
see,
suspicion, they will come. Yes, sir.
Dr. Avinash, the thing is, see, sometimes people tend to think oral cancer is only among smokers, though they are high risk tobacco users and pan masala users, but there is a significant number of non-smokers who get oral cancer. So,
Yes,
nobody should ignore just thinking that, because they're not smoking or not using tobacco, they will never get cancer. So, you cannot, everyone should focus on, high risk lesions. If it's a high risk lesion on a scan, on oral scan or any of that, that requires further evaluation. So we cannot ignore. And second high risk population is the people who have got cancer earlier.
yes,
So people have a tendency to not come for evaluation. Once they have finished surgery, they
follow-ups.
go home. So they are a population with highest risk always. So they also need a very close follow-up. Sorry,
Yes.
I interrupted.
Yes, sir. So the follow-ups and is very important. Look for second primaries in a already treated oral cancer patient. As said, that's very important. I would like to ask Dr. Paul to enlighten us about what are the main treatment options for an oral cancer. Suppose you have diagnosed a patient with oral cancer, be whatever stage it is, and then what is the first treatment that you would like to offer them? And as the stage progresses, what are the other treatments which add on?
Yeah. Thank you, Dr. Avinash. So the
Yeah.
first and most important point is that treatment of oral cancer and all cancers generally is a multidisciplinary approach. So it definitely requires input from different surgeon, from the surgeon, from the radiation oncologist, from the chemotherapy, uh, the people one, the medical oncologist as well. So basically, it requires input from all three teams to come up with a comprehensive plan. It also depends upon the stage and the location of the cancer. It depends upon what the patient's priorities are, whether the patient's medical fitness is able to accept certain treatments or not. And So, based on that, oral cancer basically has got, if I were to simplify it, the first option that we offer a patient is surgery, right? So, surgery is the first option that we offer a patient for lower stage cancers, right? Which involves removing the cancer removing the cancerous area as well as a margin of healthy tissue around it, and also removing the nodes in the neck on the side of the cancer. Then, if at all, in the pathology, once the pathological analysis has been done, if at all we find that there are any additional features that are diagnosed or determined on the histopathological analysis, certain adverse features, then we might counsel the patient to go ahead and take radiation therapy and chemotherapy as well. uh, as we go up the stage, as we go towards larger oral cancers like T3 and T4 level cancers along with nodal involvement, then the patient is counseled at the very beginning that they would require surgery as well as radiation therapy. And if certain adverse features pop up, we would require chemotherapy as well. Apart from this, patients who have got locally advanced tumors, recurrent tumors, and with distant metastasis may even be candidates for clinical trials for targeted chemotherapy, immunotherapy, uh, based on certain markers that we look for in these oral cancers. And most
Okay.
importantly, of course, we need to follow up these patients repeatedly in the long term in order to catch any kind of lesions that come back, because we know that definitely once you have cancer, there's always a chance that you might get it again. So having a close follow up protocol put into place would also really is also a very important part of the overall management.
Okay, so as Dr. Paul was saying, surgery is the main treatment of choice, and radiation is given for those after surgery as an adjuvant mainly. So, a lot of people we see in our practice have been treated with radiation due to fear for surgery or for whatever reason. Even early stages have been treated with radiation and they have come with residual or recurrent disease and they have a very poor outcome. So it is very important to inculcate the message to the general public that for oral cancer, dealing with surgery is the main important factor in the overall survival and disease-free survival of the patient. And if surgery is not done, we lose half the battle there. So, if and of course, chemotherapy is used only in cases of very advanced disease or as an adjuvant treatment in a high stage disease. Okay, so it is very important to tell the people that surgery is the main treatment of choice, and the other treatments are going to be taken up as and when they are given, when indicated. So I would like to ask Dr. Subramania if there is any recent advancements in the surgical aspect of treating oral cancer and also how to reduce the overall toxicity and the complications associated with treatment of oral cancer.
Okay. More than the advancements, I would say the best way to treat the cancer, have the best outcome is early detection and treatment. So I think the entire panel, everybody is talking about early detection and treatment, and I think that should be the emphasis, the most important emphasis in treating. So that should be drilled into the population that if they want to have a better outcome, less toxicity, then early detection and treatment is the norm. So, as you go further the treatment, so as he was telling, the primary treatment is surgery. As if it's a T1 lesion, you might even do just a wide excision or a small flap or anything, get away with that. Then, and if the stage increases, the surgery becomes bigger, the adjuvant treatment becomes more, and then all the complications, the side effects, the chances of recurrence all becomes high. So early diagnosis and treatment would be the norm. Then second would be to complete the treatment. So what happens is, say for example, we are doing an advanced stage and we do a surgery, and then the patient is advised to undergo adjuvant treatment with radiation and chemotherapy. So the problem is patients do not follow. Many of the patients do not follow or do not complete the treatment. They take half the radiation dose or take 2 chemos and leave. So that also needs to be emphasized, so that when surgery is done, only half the battle is done or 3/4 of the battle is done. The rest of the treatment has to be done as per the advice. If not, the chances of recurrence are more. And then once the recurrence comes, always the patient say, "Oh, we always knew that this will come back." And So we don't want to do anything about it. So the 2 points are early detection and treatment and completion of the treatment. So
Yes.
then of course, the other thing which really require is the positive attitude of the patient, the patient relatives, the doctor, the support staff. So most of the times, patients are depressed by hearing the word cancer. The patient relatives are. So they do not complete the treatment. So positive attitude. So there are studies which say that positive attitude does not increase, the survival or does prevent recurrence, but it will help in people, patients undergoing the treatment fully. They will come out with their problems. They can talk to people who can give advice. So I think these are the 3 main points which is really to be kept in mind before we talk about the latest advances. There are a lot of advances. There are surgeries, minimal access surgeries, which will reduce the morbidity. There are robotic surgeries which will help in reducing the morbidity, have clearer view, have access. So, for example, for laryngeal tumors, if not, robotic tumors have revolutionized. For neck dissections, robotic surgeries have revolutionized the way the morbidity of the patients. So there are some advances even in radiotherapy. The IMRT. IMRT has reduced the side effects, reduced the and helps in concentrating the radiation on the site where it is absolutely required. Then, if it is very close to the spinal cords, all these areas, the latest advances have really helped in treating. But when you said how to reduce toxicity, so I think dental evaluation, pre-operative or pre-treatment dental evaluation, and the and how to take care of the oral hygiene during the treatment, post-treatment, I think is one of the most important aspects. Patients have xerostomia. How to take care of the xerostomia? So drink plenty of water, then use gums, which are xylitol gums, which will help in improving. There has been reports saying that acupuncture has helped in improving xerostomia. So any foods which will help in improving xerostomia. Then the dental hygiene, as I was telling. So sodium fluorides application, then regular checking, then scaling. All these things will help in improving the dental hygiene and reducing incidences of stomatitis, reducing glossitis, all these things. So food, then adequate hydration, then foods which are good in
Antioxidants.
oxidants. They are good in chemo. There are some which are chemoprotective, like curcumin, turmeric, which has been coming from generations. Vitamin A, vitamin E, then cruciferous vegetables, then tomatoes. All these things are, some way or the other, have shown in whatever little way to help in reducing the toxicity. So then skin care, how to take care of skin. So patients who have undergone radiotherapy, who have a lot of skin issues. So to keep it moisturized and not to just damp and not to rub. So all these simple things together will help in reducing the toxicity of treatment.
Okay, so as Sir was saying, first thing to do is to get treated early so that you don't have to undergo all the toxicity. And the second thing, when it is not possible for you to go to undergo it early, you have already been diagnosed at a later stage, then follow the instructions that a doctor is talking to you, The doctors will tell you about all the things that you will have or how to deal with those things, because now empathy is one of the most common thing that any oncologist has towards his patients, and everybody requires to undergo a certain procedure. Then we will be telling you about what are the complications associated with it, what are the side effects that you will have to face, and how to deal with them, and you will get ahead of your difficulties with a very good outcome. And now, the recent advances mainly have been towards the radiation aspect, and towards the minimizing the side effects of radiation. We don't generally see the black tanning of the skin, total discoloration of the skin, and fibrosis of the neck area. We are now able to actually operate post RT patients also. Previously, when 3D CRT was the only option available or the cobalt machines were there, we were not actually able to operate any patient who has already been irradiated. And now going for surgery after radiation is actually becoming a possibility, and we are able to do it. Recent advances in chemotherapy have been there, but still, dealing with higher advanced cancers and metastatic cancers have still been an issue. And I would like Dr. Sandeep, the senior oncologist, to let us know about how to treat the advanced or metastatic oral cancers and what is his experience about that.
See, generally in Indian practice, we say about 60% of the patients come to us in advanced stage.
Yes.
And typically in oral and head and neck cancers, the minimally invasive surgical options are limited to early cancers only. In advanced cancers, the role is very, very limited. Uh, so minimally invasive is robotic and endoscopic surgeries, all that side. That is what is when it constitutes minimally invasive. Now, when it comes to most of the advanced cancers, I'm not talking about metastatic, means I'm not talking about stage 4. I'm talking only about the not exactly stage 4. I'm talking about cancers which are not spread beyond neck, because in oral and oral cancer, stage 4 involves multiple lymph nodes also. So
Yes.
when we are talking about cancers which are limited to the neck and head and neck, we offer surgeries followed by radiotherapy, and in those cases we might require to do a reconstruction. It could be a reconstruction using a flap which comes from the thorax, which is like either a PMMC flap or what is called as deltopectoral flap. There are many other flaps which can be used, or it could be a free flap which could be coming a flap which comes from the upper limb or from the leg, which can be used as a replacement for the tissues. Because when a lot of tissue is lost from the head and neck region, what happens is patient's functionality becomes a problem. At the end of the day, person needs to be functional. Functional means he should be able to eat, drink, and be able to talk. These are the factors which come into play for us. Appearance is the last aspect in that, because appearance also has to be presentable, because head and neck cancers have a lot of social issues are predominantly because they cannot go to social gatherings, because their eating and drinking gets affected. They tend to drool and all those things. So there are issues which need to be handled in day-to-day practice. So these are the main things which come up: microvascular free flaps, local flaps, and then followed by that there will be radiotherapy or chemoradiotherapy based on the histopathology which comes out, what all things are there in the histopathology. So these by far constitute the main therapies when it comes to advanced cancers. But when it comes to inoperable cancers, then the scenario changes, because typically oral cancers do not tend to kill the patient very rapidly. In fact, sometimes it is an unfortunate part of it, because patients tend to suffer a lot because they cannot eat. They are on tube feeds. They cannot talk in many cases. So they're basically, their suffering gets prolonged because of these reasons. So there are some things which have come up, like electrochemotherapy and all these things for inoperable cancers, but none are so very effective that we can totally depend on them. Predominantly, these patients are on either chemotherapy or immunotherapy to suppress their symptoms. That is how it happens in practice. And it's basically to give them a comfort level which they can lead a normal life, or near normal life, or a dignified life. So that is the attempt which is done in a metastatic cancer, where we cannot really give a cure. So by far,
Yes.
in summary, these are the things which we can consider.
So the advances are only mainly for curable cancers. As I was saying, stage 4 does not just mean it is inoperable or it's a death sentence. Stage 4 also means the tumor has invaded your bone, your skin, or there are multiple nodes in the neck. Still, it is treatable. It is not inoperable, or it is not. We are not going to give you away. It is just that if it is metastatic, it has spread to some organ other than the head and neck, then it is metastatic and we don't operate you at that time. So, in any case, right now for metastatic disease, chemotherapy is the only option that we are offering. Rest of the other treatments are still under trial basis or under clinical trials, and they have not yet come out into the mainstream treatment line. I would like to conclude this session and let you guys know that oral cancer is very much treatable if detected early. You can lead a near normal life with normal speech, normal swallowing, without any other complications. And once the stage progresses, all the things that you see will come out. The main problem is that the people will take examples of patients with higher stage disease only and deal with their cancer in a
Yeah.
different way. And because the people who have been treated at an early stage, they don't show as an example to others that I have been treated and I'm living normally. Only the patients who have been treated at a higher stage will show that, see, I am suffering so much and you should not get treated. That is not the example we need to set. And we need to set an example of early treatment and early disease free survival, and everything will be much better once you are treated early. And I guess this session will help a lot of people understand the course of treatments and how important early detection of oral cancer is, and how to stay away from the ill effects of tobacco and other smoking and every other bad habits that people talk about. So I would like to thank my speakers, Dr. Paul, Dr. Subramania, Dr. Sandeep, and Dr. Manish for joining me today. And I would like to thank the Oral Health Summit for giving us this opportunity to present our views on oral cancer and its early detection. Thank you all so much.
to our third panel for today on bridging the gap in dentistry with innovations in digital technology. In this panel, we will be exploring the ways in which technology and innovation are transforming the field of dentistry and improving patient outcomes. We will discuss the benefits of these innovations for both patients and the dentist, as well as the challenges and limitations of integrating new technology into the practice of dentistry. I would like to commence this session by introducing our eminent speakers for this discussion. I welcome Dr. Anil Kohli, Awardee, Padma Shri, Padma Bhushan, Dr. B.C. Roy Award, Diplomat of the International Congress of Oral Implantologists. Welcome, Dr. Kohli.
Thank you.
Dr. Himanshu Aaron, Director Principal, Professor and Head Oral and Maxillofacial Prosthodontics and Implantology, Seema Dental College and Hospital, Rishikesh, and Visiting Professor, AIMS Rishikesh. Welcome, Dr. Aaron.
Thank you, Ritika.
Dr. Praveen Rajesh, endodontist, Microsmiles Dental Care, Chennai, Reader, Department Cons and Endo, IGIDS, SBV University. He will join us in a bit. Dr. Satish Kumar, periodontist and founder, Kaizen Dental. Welcome, Dr. Kumar.
Thank you. Thank you for the invitation.
Dr. Mohammad Khalid K, consultant, dental medicine, Manipal Hospital, Hebel. Welcome, Dr. Khalid.
Thank you, man.
So, starting with our first question for today is for Dr. Anil. Sir, what is the current scenario of oral health in India, and how do you think we can leverage technology to change that?
Okay. So you have asked a very relevant question which matters to the dentist and to the common man in today's scenario. So my starting point will be a lot has been done in this field, but still a lot has to be done. Coming to the point what you raised, what is the status of the health and the issues being in society? To be very honestly, let us accept one fact. The oral health is not being considered as the important part as the other parts of the body or as other specialties in the medical field. Why do I say that? Because if for the common man, look, if you have a heart problem, he'll rush to the hospital. If you have an eye problem, he'll rush to the eye doctor. But if it's a dental problem, he'll keep on postponing. Now, why these things are happening? The reason being there is no awareness. Now, why there is no awareness? There is again a reason because we were a developing country and we are gradually coming up, and now we can trying to reach to a developed nation. Then, over and above, neither by the society, nor by the stakeholders, nor by the government or the regulating bodies, it has been given the due importance it deserves. You know, there are many things. Let's talk about very simple things. Post COVID, the biggest issue after post COVID, where the immune system was down, the oral hygiene was not properly maintained. So mycosis was the thing which was very fatal and took a lot of life. Even of the few of the dentists in even in Delhi, one of the oral surgeons, he died because of that. Now, how important is the oral health? Till day, after 75 years, what budget we have? We have budget of like 140 crores, 200 crores, and you will be shocked, my fellow colleagues sitting on the panel and the people listening to me. Can you believe what is the money being spent on the dental health? 4 rupees per person per year in today's world. And as compared to the anyway, to cut short the story, these are the we should not look only on the shortcomings. The good part I'll tell you now. See, there are three cancers which are very common because of our habits. So one is the breast cancer, second is the oral cancer, and third is the cervical cancer. Right? So which amounts to large number of deaths and things. The good part I'm talking now, the Ayushman Bharat, these three cancers have been made mandatory whenever anybody goes for the check, and this will be given to like 5 crore people and everything. So now this is a part of the screening system. So these are the positives which we are getting of these things. Getting back to the dentistry again, More than 3.6 crore people suffer from various dental disease. We are all dentists, and we need not to discuss data and all. We know how much population suffers, how many people use dental toothpaste, how many people use the dental brush. We have almost 2.5 lakh dentists in the country. Leave the dentists aside, that many number we have the quacks also. All these things. Now the problem is here, whether it is a manufacturer, pharmaceutical company, Sensodyne and all those people, or the professionals, or the society, or the government, all have to come together and come on the same platform and make a system where a common man can be benefited for the oral health. Let me tell you very interesting thing. Other day when we had this session, and they were talking about how many dentists to the population. Now we have 1.4 billion population, and they say we have 3 lakh dentists. 10,000 people have two dentists. That is not the issue. Issue is the distribution of the number of the dentists in the society in the country. Like place I practice, I may be having 500 people, one dentist, because 100 people practice around me. That doesn't matter. But if you go to the remote places where we have one dentist to 5 lakh, people don't have access. And the another important part in the government sector, we don't have all the facilities, and we are considered as a luxury. It is not considered as a luxury. It is considered as a eye opener. We all have to put our brains together, and we need to come out with a solution, not with the problem.
Yes, you have rightly mentioned that, we have come a long way, but there is a long, long way to
To
go
go.
ahead.
Yeah.
Yes, and plus, the general public is also not concerned about their oral health. They are not aware of, what they can do, and the luxury. What they think about luxury is that
Is a necessity.
if they maintain, it will not be a luxury, but if they don't prevent or maintain, if they don't go regularly to the doctor, then it will become a luxury. It is not a luxury, but you make it a luxury, so
It
that
is
is
not a
what.
luxury till you suffer.
Yes, exactly.
I'll
And
add one. Ritika, sorry to
yes.
interrupt. I missed on one point. Let me put that also forward so people should know about that. When this country got liberated, the average of a human being used to be 37 years, and today it is 69 years. So when you have to live longer, so you need a better health. When you need a better health, you have to eat better. If you have to eat better, you need a better teeth. Geriatric dentistry is a need of the hour. People are living like 80, 90. It is not like 37 or 60 or 40. People will die. So for the longevity also, if we look into all these statistics, and the government has to look into the factors, and we also have to look into the factors, and to provide the best possible oral health and dental care. And post-COVID, it has changed the way of life. So there are a lot of things for us. So we should look into all these factors and come with the solution and overcome the problem.
Yes, you have mentioned it very correctly. And plus, one thing that you said was that, in we think about that there are 100 dentists around us, but that's the scenario of metro cities and tier two cities. But once we go into the rural places, they don't have awareness, they don't have dentists there. A bunch of quacks are sitting there, and they are operating, and they are not even telling them what to do, how to prevent these kind of diseases, and the awareness is lacking between those lines in the
Yeah,
rural area.
education is needed, and it should start from the school level.
Yes, exactly. So with
See,
that,
I tell you, I'll just compare these things. As the age is growing and we are getting developed, and the Google and nature and everything. Now the young girls are being taught about the medical issues at the age of 10, 12. Puberty sign and all. The same way, it should be part of the system where we should tell them the importance of the oral health and the general effect on the general health, and how you can prevent all these things. So you compare from those fields, there's so much of advancement, whereas in our field is not up to the extent which should be there. It is there. I won't say there is absolutely nothing, but there is a need for more.
Yes, rightly pointed out that there is a need for more. So, with that, moving on to my next question to Dr. Himanshu. So, what are the most significant? So, we talked about, that we have reached a certain level. So, what are the most significant recent innovations in implant dentistry, and how are they improving patient outcomes, sir? You are on mute, sir.
Hello. Yeah, I'm a prosthodontist. The first statement I will like to say about dental implant. Dental implants are the replacement of the missing tooth or teeth, not the natural teeth. And unfortunately, there is a practice that we are not trying to save the natural teeth, and due to some unknown reasons, we are just switching over to dental implants. The first thing I would like to emphasize as a prosthodontist or as a oral implantologist to all younger generations, please don't compromise with the natural teeth. Up to what level we can save natural teeth, they should be shaved. There are lot of endodontic modalities there, periodontal modalities are there, because we can't replace nature. Implants are the replacement for missing tooth, not for the teeth. So this is my first request to everyone. Ki please try to say, we are having a big endodontist of the country, which is Dr. Anil Kohli sir. He will agree with me. Now there are so many treatment modalities available, and the jaw reflex, then the this what you call mucous membrane support, and all these things are there with the natural teeth, which are going to miss with the implant. The first thing, please try to save natural teeth as long as you can. Now coming to the dental implant. Okay, dental implant is a promising treatment modalities nowadays, and with the advent of the CAT cam, CBCT, we can do better diagnosis. So I will advise, whenever you want to put a good implant, so you just don't depend on intraoral X-ray or OPG. If you have the facility of CAD CAM, so you must go to the CAD CAM of the region, so that you can know the quality of bone. Because any dental treatment is main success criteria for me is the longevity. And if bone is there, bone is good, then only we should plan for the implant. So we should have full use of CAT cam. And nowadays lot of implant companies are there, and lot of different types of implants are there. When we are talking of recent advances in implant, so they are short implants which are used in ectropic range, where we can't put the longer implants. They are tilted implants or angulated implants, where we can't have the direct crown formation on the regular implant. Then we can use the tilted implant, like in the case of posterior maxilla. Now recent we have zygomatic implants also, with anchor itself into the zygomatic process of the for stability. And transmucosal implants are there. And now when we are talking of recent advances, the most important thing is osseointegration, because the success of implant depends on the osseointegration, and osseointegration depends on the surface of the implant. So nowadays we are having various kind of surface treatment for the implant. So we have can choose the implant which are having the surface treated, because as you know, osseointegration is basically the basic key of the longevity of the implant. And rougher implant surfaces are generally more favorable for osseointegration. And rough area, because rough area increases the area for the osseointegration or bone implant interaction. And if surface is rough, then it is the faster healing times is there, and patient can go on their regular life more quickly. Durability, as I told you, durability is the most important factor for any successful dental treatment. And plaque harboring, while rough surface are otherwise more favorable for implant oval success, but there may be a plaque accumulation if it is exposed. So these are the advantages of the rougher surface. And we are having threaded implant, we are having the implant with the crisscross things. So these are the recent advantages on the implant. And another the breakthrough development as a prosthodontist, what will I will like to emphasize here is CAD CAM. Earlier, we are dependent on the routine burnout technique crowns, which are not that good fitted as the CAT cam crowns. So CAT cam crowns, we call it one day dentistry. It may be, but this the another well beautiful feature about this is their surface fitting is very good. Their surface roughness is less, and soft tissue adaptation of the tissues around the implant is much better than lab fitted crowns. So CAD CAM is another major through achievement in the field of implants. These are
Thank
the
you so
things.
much, Dr. Himanshu. Yes, you have summarized all the recent advancement that happened in the implant industry, including CAD CAM and shorter crowns, shorter length implants. So thank you so much, Dr. Himanshu. Moving on, we have covered implant. Now moving on to the endodontics part of it, I would like to ask Dr. Praveen, what are the benefits of using digital documentation in endodontic practice, and how does it improve your patient outcome? You are on mute, Dr. Praveen.
Yeah. Hi, Dr. Ritika, and good afternoon to all the respected people in the panel. Big people like Dr. Anil Kohli, Dr. Himanshu, and Dr. Mogal, all are there. I'm very happy to be amongst this group today. So, digital documentation, basically, what we do in our practice is we take photographs and preserve them for quite a long period of time. And we found that this particular practice not only helps in patient education, like I think before this you were discussing about how many clinics are there around you in a tier one city. Literally every area has around 100 to 400 clinics. I practice in Annanagar, Chennai, and Bangalore, and I can easily say there's in Annanagar itself there's around 400 to 500 clinics. And if a patient has to look at your practice, if you want to attract that kind of a clientele, which where you want to do something different from the others, you want to provide something of that quality and standard, the patient has to see it first. So the main thing is photography. Photography inside the tooth, outside the tooth, whatever it is, patients believe it only when they see it. Also, the record keeping is so important. Unfortunately, many doctors don't are not trained properly in the dental schools. I would say they feel photographing their own work is just to show to the staff, and they don't care about it, or maybe putting it in social media. But the record keeping has saved us so many times. In fact, we did almost 5 to 6 crowns for a patient around 6 years back, and he came back to me 2 years back saying, "Doc, see, two of your crowns came out," and I was like, at first instant, I thought I did it myself. I thought, the crowns actually came out. Then, looking at his pre-operative pictures, I understood that it was done even before he came to our clinic. So we were able to convince the patient that it was done prior and it wasn't our work. But even if I had said this by words or by record saying that tooth number 3646 I did not do 3748 and all, he's not going to believe you, right? So one is to gain the trust of the patient, to save yourself from legal complications. In fact, I think IDA has this rule saying that you need to keep patient records for at least 8 years. Correct me if I'm wrong, but this is what I read in one of the IDA websites. So 8 years legally, you are mandated to keep all the records of your patients, including photographs, models, and clinical data, the diagnostic and treatment plans and everything. So photography is like a part of everyday practice. It should be a part of everyday practice for everyone, I feel. So I feel dental photography should be a part of our regular curriculum. It's going to make a big difference.
Yes, you have rightly pointed out, and in US or so, there is a trend where not just a trend, they have EHRs and EMRs, electronic medical record, electronic dental record keeping, in which
Right.
they record everything, whatever the cast, the models, and everything. And I remember when I was doing internship, we were made to record each and everything. The whole history of the patient, what you are doing, and how you will further move ahead, and what will be the follow-ups for that patient. So we were taught to record, but as you move on to the dental practice and a lot of patients are coming in, we usually tend to forget that. So that is an
Okay,
important
so
part.
that's one thing, Ritika, where you need to work with a team. So when we say dental documentation, it has to be a team effort. Of course, the dentist himself will be the lead of the team. He's going to train all his staff, but it cannot be done by one person single-handedly. So what we do here is we have trained our assistant in photography. So they take the standard set of photographs, occlusal, frontal, upper, lower. Okay. After the standard set, the consultant dentist will come and take some strategic photographs where the patient's chief complaint might be there, or maybe during the root canal, you want to show the patient that there's a missed canal here. So I would take another photo there. So, and then we show to the patient. This documentation starts right from the reception, where they record all the demographics, then your assistant, where they record the basic findings. Then maybe if you have an assistant doctor, they can record certain other important parts of the history, like your medical records and all those things. Finally, the consulting doctor should be, be a part of the documentation. So when you work with a team like this, I feel you can do this for each and every patient that walks. Even if you see 50 OP, and every record that you make should be put in a EMR, electronic medical record. We are out of the age of era of papers. Of course, people with old practices do still follow papers, and they have a wonderful system to keep it. So if you have a wonderful system, let it keep running. But I feel electronic medical record keeping softwares are very good nowadays. They give you a lot of storage spaces to keep all your records. So please utilize them and keep a dedicated person who's in charge of uploading all this data to the electronic medical record. And it has to be accountable. If that person doesn't do it within 24 hours, make sure that they're asked why they didn't do it. Because I found that if my assistant doctor doesn't do this for more than 48 hours, she forgets it. She puts one patient's record to another patient. So a lot of juggle buggle happens. So be very careful there. And if you say that you have a lot of cases I cannot record, then I would like to give you an example of CDC, Children's Dental Center, Korea. We had the opportunity to visit their clinic in Korea. They see literally 60 to 100 cases of pediatric appointments only. And they have 4 doctors, and everything is documented. They have 3 assistants per chair, and the assistant do all the documentation. The doctor just does his work, and all the documentation is done by assistant, right from record entry to everything. So it's all about how you train your staff.
Yes,
Ritika,
rightly mentioned. It is a yes, sir.
Ritika, what Praveen said very rightly, I will add on one line only. Why this record keeping is very, very important, and not in our country, but Europe and America, because of the insurance. And the insurance is the future for the dentistry in this country. And it is always better you teach them when they are young. They call it them catch them when they are young. But I will call teach them when they are young. Now we have a large number of dentists. We have a large number of dental schools. The future of dentistry belongs to the insurance for the common man. And insurance will not work without the record keeping. Now, what he was saying about IDA, ATS, and all, very good, but this is not mandatory as of now. As with my experience, it is your sweet will. You are getting into the habit of keeping the record, which will help you in medical negligence, as well as you said, we also said the same thing. You made this crown in small, whereas you never did it because you will stay in the record. Like you have written a prognosis is not good, patient insisted for the treatment. I did it. It is a compromised treatment. Tomorrow if it fails, I have my records. I can do it. So it is a very very important point which Praveen said, and I just wanted to add on because insurance is going to come soon, and we should be prepared for it, and we should be ready to start with the record. Thank you.
Rightly said,
So
Dr.
thank you, Anil sir. So what do you think is the preventing insurance from coming in? Because I think insurance, like you said, is the future. If all
Should
the
I tell you?
doctors have to be,
Should I tell you? Should
Yes.
I tell you? I tried 10, 12 years back with the health minister and all is a mindset
Oh, it's a
and
mindset.
stakeholders and stakeholders. Same in the oral health policy or in anything if you talk. Only thing our way of thinking and has to change. And it has to be collective, not Anil Kohli or opinion can see. If we all put our heads together and then we can reach better heights.
I
Simple
totally agree with Kohli sir.
Take a simple example. Why don't we have research? Because there is so much of clinical material, there is so much of clinical data, but we are not in a habit of keeping the records, nor we are in a habit of research, which is a very, very sad part.
Like I said, in that Korea, in Children Dental Center, my wife went to do her PhD entirely based on the records they've been maintaining from last 20 years. They
Yeah.
have CBCTs and photographs of all the patients.
And
So
what you rightly
it's
said,
like it's like gold mine.
future is one because of insurance, and second, artificial intelligence is going to play a big role in days to come. Patient will have a reach to take your record to the X doctor or Y doctor, anywhere sitting in US or in Korea or in India. He can follow it up and he can tell you whether you're right or wrong. So patient will have a choice. So we have to start getting into the system and start learning these basics. I'll call this is a basic, and this should be taught at the first year or second year of BDS curriculum.
Correct,
Yes.
sir.
Yes.
Rightly said that, once insurance comes in, I think everything will fall in place. Yes. So,
I think it's
moving
getting
on to
interesting.
yes.
Everybody's taking too much of time.
No, no, no.
Discussion is
So,
getting this is discussion is getting fiery, huh?
so I think this discussion only will, open our ways. People will listen, and we need a platform to share our thoughts, basically. So I think a platform can create a lot of buzz in the market. Then, we were talking
Actually,
about dental insurance, and
as
so
Dr. Kohli very rightly said, we need a team effort.
yes.
Unfortunately, we are not working on team efforts.
Exactly, sir. Rightly pointed out. So moving on to Dr. Satish, sir, how can young dentists leverage digital technology to grow their clinical practice?
Okay, now this will be an amalgamation, I think, of what Dr. Anil Kohli said, Dr. Praveen said before. If you see that when you, in say 20 years ago, if a young dentist had to differentiate himself from an older dentist who's practicing for 15 years or 20 years, how would you do it? That person did 20 implants, 20 dentures. The senior dentist has done 200 dentures. So how do you show your patient you're better? But today, things have changed. Technology is in the hands of the younger dentists. So the younger dentists can use technology in each and every step to move and leapfrog ahead. Now, in each and every step means what? Let us look at the life cycle of a patient. How do you get a patient? A patient comes to know about you. In today's day and age, you do not need to have pamphlets. You do not have to go verbally and talk to patients. You can use digital technology, that is social media, Google, SEO, and other things, where you can directly reach your patients. There are no middlemen in between. Okay. This is the first stage where you use technology. The second stage you use technology is once the patient comes to you. How do you differentiate? How does the patient feel that you're a better clinic? Like Dr. Praveen said, you have everything digitalized. So soon as the patient comes in, you have record keeping, you have an EMR, which where you store all the data, you keep all the records. So the patient, once he walks into your clinic compared to another clinic, he sees that differential, the way you are managing your practice. Now, after this part of how you take the patient in, how you treat the patient, that is where Dr. Himanshu sir was speaking about. How do you treat the patient? You can do single day dentistry. In today's day and age, you have intraoral cameras, you have CBCTs in your own clinics. Now, just I want to take you all back to say around 10 to 15 years ago. RVG having in a clinic was a huge thing. Maybe like around 10% or 12% of the clinics all over India had an RVG. But in today's day and age, 90 to 95% of the clinics consider RVG as a basic part of setting up a practice. Intraoral cameras and everything, and intraoral scanners are going to be the future, say 10 years or 15 years from now. So the younger dentist can leverage it and use it from now itself, where you can show a difference between RVG and RVG plus. And that is where you can provide, like how Dr. Imanshu sir said, single day dentistry. So that single day dentistry is something which you can again leverage. Now, this is when the patient gets over, your treatment is complete. Now, how Praveen sir said was, if you have an EHR or a EMR system, that is basically where you keep your records digitally. 6 months later, you can have many of these apps like Practo, Bestosis have this system. 6 months later, the patient gets a message stating that your treatment has been done. 6 months are over. So it is time that you visit your dentist and check everything is in place. Okay. If the patient does not come, if you have a receptionist, your receptionist can screen this data and again call them. Okay. And then you can use their mobile numbers, the WhatsApp content, and everything to provide them various basic dental treatment options. Now, for example, a patient has got a treatment done. You advised him an additional treatment, maybe he has a missing tooth. You explained him implants, and patient has not got implants done. He just got his root canal done. You can send him clinical data or a video or a message stating why dental implants are important, why should he think about it. So this is keeping yourself in the mind of the patient even after 3 months or 6 months after his treatment is completed. So young dentists have been using technology, and they are the ones who should try and inculcate it in the practice where the future is. Like how Dr. Anil sir was saying about AI and everything, that may be 15 or 20 years from now, but this is where the basics start, and I think young dentists are in the forefront who they can leverage this easily.
Yes, so you have mentioned that you we have to create a habit of doing all these things. So this include the marketing part as well, which you have told that
Absolutely.
if follow up is not happening, you can uh, uh, basically it comes to that the data you maintain. So the kind of data you are maintaining, then you can take the follow up and everything. So that is how it happens. Plus the
Yes.
technology, how you leverage that technology in your dental practice, that is the other thing. So we have talked about technology. So but for Dr. Mohammed, I would like to ask you the challenges. So what are the current challenges that dentists face in India, and how do you think we can overcome those challenges? So
Okay.
I
Good
think
afternoon
this
to
will be
everyone, all my colleagues.
a long answer.
Yeah. Now, this question is a very dicey question because, as my colleagues, all of them have spoken. Anil sir has spoken, Himanshu sir has spoken, Dr. Praveen, Dr. Satish. See, the first basic thing is we are talking about India, a developing country. So the facilities and whatever the investments required, everybody cannot afford it. The number of dental students which are coming out today in India out of so many dental colleges, I think the ratio is exponentially high, wherein all dentists don't get an equal amount or equal chance as to stand and practice in a luxurious practice. There are some basic clinics. See, now we can classify the clinics into different area zones, as Sir had said, the urban clinics, semi-urban, and the rural clinics. Where can you expect a person who in a rural clinic to have an RVG or any other digital mode of explanation or other things? Whatever is done is basically done by the doctor himself. And today's doctors, among the number of students which are passing, sorry, students which are passing out and coming into practice, the biggest difficulty is the challenge is they do not know patient management, I would say, because we are taught subjects in colleges, we are tutored on all our specific details, but patient management, patient explanation, people don't know how, we are not taught that. I think this should be incorporated into our education system as such. Second thing which mainly implies in this is that the exponential increase in the number of dentists, it's become a rat race. The number of dentists to the number of the people present out in the population, as Sir had said that Anil Sir mentioned, it is exponentially high. Every road has around 10 dentists, 10 to 15 dentists. Number of dental clinics are so many. So the quality is itself compromised here.
because the public exact what they want to start doing is they start hopping from dentist to dentist. It's become like a cloth shop. They go check which price is where it is low, where it is high. So at this point of time, what happens is our dentists are facing a problem wherein they are not allowed, or we are not being what do you I would say that they're not being given a chance to explore out avenues. See, a niche practice, yes, as Dr. Praveen said, can have all these features of digital recording, having assistant. Today, tell me one thing: how many dentists are there who have how many assistants in their clinics? Yes, a well-profined practice will have assistants, as doctor, assistant doctors, people to take a photograph, people to take other things. But can a normal dentist do this? This is what I would say. It is, let us be on a practical ground in India. What are facilities we are not able to give to our patients is because of, number one, the cost. We face a very basic financial crunch. The patients walking into us are ready to bargain, like in India. Tell me one thing: do other patients go and bargain with other doctors? The first thing is, in India, dentists, people have a variation between a dentist and a doctor. When a diabetologist or a physician or they talk about their consultation, patients are ready to pay this and go. But when a dentist is in place, they're not ready to pay a consultation. They say procedure charges, we are charging a procedure charge. They want it to be included with that. So tell me, how should a person suffer out with this? That is, my fellow practitioners who are fresh and young graduates, how do they practice out without being paid adequately?
Right, you have very rightly mentioned. Dr. Sandesh also, told something like that. That if a doctor is for a operation, if a doctor has said that it will take around 1 lakh rupees, but if the bill comes around 4 lakh, the patient readily pays that. But if we come to a dentist, he wants us to leeway the charges, the consultation fee as well. So yes, Dr. Himanshu, you want to
Yeah,
do
Yep,
something?
yeah, I've seen that in Bangalore. So
Dr. Khaled, I will ask simple question. Who is responsible for all this behavior?
Yes,
Only
yes.
dental.
We as dentists itself are responsible for this, sir. I strongly agree, because there is a lot of problem is the we don't work as a team. As Dr. Satish and Dr. Praveen mentioned, we don't have a team practice. But what is happening is the neighboring dentists in the same area of a clinic, if a patient hops into their clinic from your clinic, they, instead of just neglecting, okay, there must be a mistake. I don't say that there may not be a mistake, but they would exaggerate that mistake to such a big extent that we are criticizing our own colleagues. At the end of the day, people start
No,
misusing this against us.
Dr. Khalid, it is
Exactly.
everywhere. It is not only in dentistry. In every
No,
profession, it
sir.
is like that. But we have to be very ethical in our practice, and as we are talking about digitalization, we should be very transparent in our practice. When we are having records, then we are doing ethical practice. As I told in the beginning, patient is not requiring implant, and we are jumping on the implant because of just money factor. So these type of habits we have to control, and it's more applicable for youngsters. I think Dr. Kohli sir will agree with me.
Yeah, I'll add,
Dr. Kohli has not become Dr. Kohli in one day. He has spent life to achieve this all Padam Shri, Padam Vibhushan, VC award. He is a
Sir, from
dedicated
the time
person.
we joined the dentistry, we are hearing Dr. Anil Kohli's name, sir.
So
Mohammed,
then,
I think my
Sir,
colleagues agree to this.
I, I can
Khalid,
say
yes, of course.
number of dental surgeons is not going to hamper us. Sky is the limit still.
no, but I would like to add a few things.
After Satish, I'll take it, then you can speak.
Sure, sir.
Khalid, you raised a very, very sensitive issue. And you are being honest, and you said something which really is a reality of today. There are two things which are spoiling the profession as well as the treatment.
Correct.
See, anybody coming to you, you are supposed to do what you can do. But to criticizing your own colleague or your neighbor is the worst thing a professional can do, and it is most prevalent in the dentist profession. Let's be honest. That is number one.
Absolutely.
Number two, which is the thing which is very, very detrimental. These lot of companies coming with 300 clinics, 400 clinics. Their main aim is money. Advertisement advertising is spoiling our profession. Now here, the regulatory bodies come into picture, whether it is a state dental council or it is a national dental council and all, they should play a role. Like you take the example, if you have to close a quack, how do you close? You can't do help it anyway until unless the regulatory bodies of the government of India or the state government or the state council plays the role. So biggest dental in our profession is our own people. In place of thinking of doing, see somebody coming to me, I said, listen, we will talk what you are right now. Don't tell me who did it before, how he did, what he did. I'm not answerable, nor I will answer. I will do. I'll tell you this is he did, I'll do for you. So ethics, but it doesn't come overnight. The problem is like people like I passed out a dentistry in 300 rupees per annum, 1200 rupees the total cost of my education. Now the people, those who come after spending 20, 25 lakhs, they want overnight. So there is not overnight money. So then they go for unethical. Thank you.
Very rightly said. Thank you, sir.
Dr.
Dr.
Satish wanted to
Satish,
raise a
you
point in
wanted
this.
to add something?
Yeah.
Yes.
See,
Please,
now,
it's a dangerous point, but I don't mind saying.
no, of course, sir. No, the first thing we were talking about, how you were telling that in a rural area, this is not possible. I want to ask you, everyone has a mobile phone today, which is a smartphone. Any dentist would have at least a 15,000 rupee phone. Okay. What is stopping that dentist from clicking photos with his phone? Majority people have a laptop of their own. What is preventing them from saving that data in the laptop? Now, the same people will tell you they do not have enough patience. If you do not have enough patience, you do not have enough team, why don't you take the photos yourself and do the data entry yourself? If you do not want to have an EHR, now 15 years ago when I started my practice, I didn't have Practo, I didn't have Bestosis, there were no these EHR appliances. But I have data from the first day, first patient I did. I had basic Excel entries. Okay. Who does not have Microsoft Excel in their phone or in the laptop? The problem is it is easy to criticize people in power when we are on this side. We are not as dentists doing things which we can do in our control. Now, for example,
Correct.
Dr. Praveen mentioned basic photography is not a major skill. Patient is not looking for whether your quality is Oscar winning or something. If you can take a photo where the crown is not shown in that tooth, or if the patient has come, there is already a crown, you can easily show that this crown was done before you came to me. So for that, skill is not required. Now, when you're coming to things like patient bargaining, why do patients bargain? Is we have inculcated this habit.
Be allowed.
Have you ever seen a dermatic inculcating
Yes.
this habit? Why are we has see if the quality increases now, if you start using better materials, automatically you will have to start charging more. If you start charging more, automatically the basic price will increase. After COVID, lot of at least 90% dentists increase the rates. Automatically the base rate of dentistry has increased in 1 year. How did that happen? It is basically a mindset which we dentists need to inculcate, and that can happen like each one teach one. We will have to keep motivating people around us rather than telling there are a lot of dentists. There are a lot of dentists in US
So
also. There are a
that's
lot
why
of
I said,
dentists
sir, we should
everywhere.
teach patient management skills at the college level, not after they come
100%.
out of college.
Yes, and even ethics, like how you
Yes,
mentioned. Ethics
yes,
should not be like you mug up from your community dentistry or PhD, what is called now.
yes,
It
yes,
should
yes.
be first day you come, there should be a topic on ethics. There should be a proper separate exam only on ethics of how not to bitch about your adjacent dentist. There should be patient management, which should be taught basically. So these things I think should be initially inculcated, like Dr. Mohammed told, and that is where difference can happen.
Correct. I think our apex body is doing something on this
Yes.
on these lines. Let us hope for the best.
He very rightly said we should not criticize and we should talk about the constructive thing, not the destructive thing. And each one is responsible for that. Let's be honest about that. Because I
Yeah, I
faced all
think there
this
should also.
position. So this is absolutely bitter truth.
So I want to interrupt. I just feel
Sure.
one thing should be inculcated among all our co-colleagues is that using of standardized material, not using materials. Because what happens is now the biggest problem, as Sir had, as Dr. Satish and Dr. Praveen mentioned, is that even though we provide the best of quality, the patients will start comparing with other clinics who are charging lesser. So a standardized, a minimum standardized rate in all state, like you have this Karnataka State Council or any other state councils, if a minimum base price has been set, I think it would be much better for our colleagues to practice. Because what happens, trying to grab the patient or trying to explain to the patient to show that he's better than the other, we are actually dropping ourselves down. So because at least if we get a base price tag set for our patients or in general, what happens is the quality can be, the pricing can be always increased based on whatever quality standards we are maintaining. But it will not drop to a level wherein a patient is, a patient is taking advantage of our colleagues or us itself, that they're comparing with the other person. As Anil sir said, we should all have the strategy of talking to the patient in a very simple line, that don't tell me what has happened, tell me what is there in the present.
Yeah. Mohammed, what you raised very rightly, I will put it again as a personal consciousness of the professional. Now, these things, even if you make the rule, there are people those who will break the rule. So it is on the personal note. If you ask me, it is your self consciousness which responsible for giving what quality, what material, and all.
I think rules in our country are still not
Rules are made to be
very
broken. Rules are made to be broken.
especially in our
You are
country.
you are
Yeah.
saying this, Dr. Kohli. You are saying this on a
I've
platform which will
seen,
go live.
I've
on.
seen the people where you make the rule. I'll give you the example. I put 15 years back in every college the biometrics, and it was broken by my own colleagues.
Yes, correct.
Let's be honest. One should not be afraid of anything. This is the reality. Why we have the problem of backbiting of our own professional? These are our own professional colleagues. Nobody comes from outside. So we have to change ourselves. We have to think of our own self and our self-conscious.
I think this
Yes.
entire thing should be one subject itself in dentistry.
Yeah.
I
Yes,
feel in
yes.
fourth year it should be
I
one
think
subject.
patient
Dental
management should be made as a separate.
This is endless discussion. Go ahead.
It should be taught.
Yeah, if you
Yeah,
go
because
ahead.
we are trying to encourage doctors to refer difficult endo cases to us, but they rather extract and do an implant rather than refer it to a different doctor. So we found maybe out of 50 doctors, maybe 2 or 3 of them actually refer us. I feel all this should be a part of the
In India, there
curriculum
is
itself.
no concept of group practice.
Yeah.
Dr. Praveen,
Group
as you
practice and
mentioned,
referral practice.
reference practice and group
Knowledge
practice in
of-
India, they don't want to do a specialized practice. They want to put their hands into as an
Exactly.
orthodontist, but everybody wants to put their hands into everything.
Himanshu,
Yes.
I'll tell you very interesting.
No,
I'm in practice for the last 4 decades, right? I've seen there was a time when there was only one specialty which was being exclusively practiced. You know what was that? Orthodontist.
orthodontist.
Now, what orthodontist used to do? He used to send the patient for extraction, and patient was sent back to the same doctor for extraction, and then he goes back to the orthodontist and he was doing. What is today? If he sends back, the patient will never come back because he also has. So
I think
that
this
is what it is.
discussion is going
That is
to
what it is.
is a
That is what
very
it is.
this discussion has been very interesting, and we have lost track of time while discussing all
Okay,
these
so
things.
That is
So,
why we stop.
for next 10 minutes, we'll be precise 2 minutes each.
so no, so I won't ask any other question from because I know you have a practice to attend. But one thing that I will ask, so I have cut down all my questions now because this discussion was so interesting that
so
everybody got
interesting.
in touch.
No, you continue with your questions. I think that will be better because this discussion is endless.
Yes, so I just want to uh, get a one liner message from each of you. Instead of those questions, I will like to ask one liner message that you want to give to your colleagues, to the general public, starting with Dr. Himanshu. So yes.
Actually, I just what we are discussing, we are talking of ethics. So you just treat your patient like a god. You can't deceive God. Similarly, you should not try to deceive your patient. So whatever is best possible for him or her, you always suggest for him as per his oral condition, as per teeth condition or financial condition also. Because we have to keep in mind everybody can't afford implant. So whatever is the best treatment plan, you should explain the patient and within the limitation of his or her budget, you give the best possible ethical treatment. This is
Rightly
my
said, Dr. Manshu, that yes, yes, we should always hear what the patient has to say first, and then we should treat and think of the other methods. So, moving on to Dr. Kohli, I know you will have a 2-3 minute answer. So,
One
Mine will
like.
be see, firstly, a proud Indian, proud dentist. The country has given us so much. All of us have a responsibility to give it back to the society, especially to the people those who really need. And the last line for the professionals: be honest, be ethical, and give back to the society. Jai Hind.
thank you so much, sir. Thank you so much. Now, moving on to Dr. Khalid.
Yeah, I would only say one thing in this is that I believe in one concept: fear of God is the beginning of wisdom. So, once you fear God, do your best for your patient, treat your patient like God, and give him the best. And second thing, I would just want to add one point in this is that always try to explain to your patient the complete treatment. Explain to them what is their condition, show them their condition from it as with using intraoral cameras or even just a simple mirror. Show them what their condition is, explain to them the treatment, explain the pros and cons of treatment, give the various treatment options so that and try to make it more cost effective. It should not become an exponential increase depending on the infrastructure of your practice or clinic. So try to make it as good as possible with the best. I would not say have a loss, but give them the best deal that you can do it.
Thank
Thank
you,
you.
Ritika. I'll be just getting out now because my people are waiting outside.
Understandable,
So,
sir.
wonderful session and nice meeting Praveen, Satish, and
Nice.
Khalid. Himanshu will keep me. Thank you, Ritika.
Nice, sir.
Thank you.
Thank
An
you so
honor
much,
to meet you,
sir.
sir. Thank you, sir.
Dr. Satish, moving on to you.
Uh, Actually, I have a lot of points to give. Let's keep it to one. There is a state of fear among the young dentists. Okay. If you see the discussions we had and everything, there is a lot of negative bias. But if you
Actually,
actually
even I
see,
had that. I
measure
had fear in third year BDS. From third year
exactly.
BDS, we had this fear. What am I going to do after BDS? Everybody has it.
Yes, everyone has it. And if you
Dr.
actually
Praveen, this was
see,
my thought process the day I got my degree in hand. This was the same thought which I had. What am I going to do next?
Yeah.
and here you are. This is what I want to tell the young dentists that each and everyone who has been through this entire process had these same fears, these same scary thoughts. What next, or how am I going to survive? There are 100 dentists out there. But I'll be honest with each and every young dentist. Most of the dentists are only cribbing. Everyone is making adequate enough money, everyone
Correct.
is doing well. If they were not making money, why would you have 10 clinics? They would shut it down and work in a call center. They are not doing it. Means majority of dentists are doing well. So that fear psychosis of I will do well or not should be removed. That is the first step of getting into clinical dentistry. And the second step is mindset. This mindset is that if I increase my charges by 200 rupees, will people come to me? If I increase my charges by 300 rupees, if I'm more expensive my machine than my Pachwa, will people come to me? This is this fear or lack of self-confidence which people have. They have to work on increasing that self-confidence and self-worth, that you are relieving the patient of pain. You are creating value. Create value and show that you are creating value. And patients will be willing to pay what you're worth. So that mindset shift is something which you need to work on and remove the fear completely. These are my two takeaways to the young dentist watching.
Thank you so much, Dr. Satish. Moving on to Dr. Praveen now.
No, actually, amazed. I was like mesmerized by Dr. Satish's talk. And no wonder he has so many followers on YouTube. So, like he said, young dentists have to eliminate the fear of charges. I feel that's something most of us go wrong with. Initially, we say we have a new practice. Let's start from little less. It's okay. It doesn't work that way. You have to know what your worth is, and you have to charge from what you really want to be. 5 years down the line, if you want to charge 10,000 for root canal, I would say start from now, because I feel if you charge in a tier one city anything less than 6 to 8,000 for root canal, you're not doing justice for your the value that you're delivering. Okay, so one is lose out your fear. Second thing is, if you want to really lose out the fear, think whether you want to be a king of your trade or a jack of your trade. Like, a jack of trade will learn everything but very little of everything. I would say become a king in one profession, one uh, small area in dentistry, and become the king there. And patients should come searching for you. So right from day one, after your graduation, keep that one small area of focus and work all your life towards it. And you will invite referrals. You will get patients who will come all across India or all across the world just for your work. And like everyone said, work with don't work with a scarcity mentality that there are so many dentists. There is something for everyone, especially when you know you're the king of your trade. And remember that you can never become the king of all the trades in dentistry, because dentistry is a vast ocean. You can be a king in one small specific field, and you can excel in it. And you'll be able to provide 10 times more value for your patient when you excel in one small field.
Thank you so much, Dr. Praveen. So it was a very wonderful discussion today on this platform, and I would like to thank all the speakers, to getting time for this, to scheduling this, and taking time from their schedule for this discussion. Yes, so I would like to thank you, Dr. Himanshu, Dr. Khalid, Dr. Satish, and Dr. Praveen, for being here with us for this discussion. Thank you so much.
It was really amazing. It was a
Yes,
wonderful
Thank you so
conversation.
much.
We went completely
wonderful
off
Thank you,
track,
Dr.
but we all
conversation.
Praveen.
enjoyed.
Yeah, we had a nice
It's
conversation.
it's
Thank you,
happy
Dr.
to know
Ritika,
many
for
people think
holding
like
such
you. Yeah.
lively discussions. And I hope young generations will be benefited for
Exactly.
sure.
We'll
And
be
general
able to
public.
learn a lot of things. Yes, sir.
I would like to
Definitely.
conclude by saying we have to create awareness for dental diseases and for oral health care. That is the basic which is missing in our country.
Exactly. Rightly pointed out,
Yes,
sir.
sir.
Very rightly said. So I will conclude this panel discussion here now. So thank you so much for all your time. Welcome to our last panel for today, Shaping the Smile, a way forward for dental aesthetics. Today, a smile is often the first thing people notice about us, and it can have a significant impact on our confidence and self-esteem. With advances in technology and techniques, dentists can now help patients achieve the smile they have dreamed of. Our panel comprises leading experts in the field of dental aesthetics who will share their insights and experiences in shaping the smile. We will discuss the latest trends, techniques, and technologies that are making a significant impact on the dental aesthetics industry. I would like to commence this session by introducing our eminent speakers for the discussion. I would like to welcome Dr. Anish Naware, Director, Integrated Endodontics. Welcome, Dr. Anish.
Welcome. Thank you. Thank you very much
Uh,
for inviting me for this platform.
Dr. Shanti Priya Reddy, Consultant Dental Medicine, Manipal Hospital, Old Airport Road. Welcome, Dr. Reddy.
Thank you, Ritika.
Dr. Shraddha Shetty, Consultant Orthodontist, Ruby Hall Clinic, Sassoon. Welcome, Dr. Shraddha.
Thank you. Thank you, Dr.
So, moving on to this discussion, I would like to ask Dr. Shanti Priya. So, ma'am, can you discuss the link between oral health and overall health, and how poor oral hygiene can affect a patient's well-being?
Yeah, hi everyone. So, did you know that almost every year, nearly 3.5 billion people suffer from oral infections, and also often associated or linked with other serious health issues. It is said that a healthy mouth or good oral health is a window for general or overall health of the person. And let us look at this how a link is formed between poor oral health and the systemic diseases. So, first and foremost, when you have a lot of infection in the mouth in the form of dental cavities or gum infection or periodontal diseases, what happens is there is a lot of bacteria growing in the mouth in the form of a biofilm, and then these bacteria gets released into the bloodstream along with their products or toxins. They can enter anywhere in the body, and it can also affect other systemic organs. So, one such link has been formed between, I mean, there are many systemic diseases that have been linked with the poor oral hygiene, and some of these diseases I will briefly discuss. So, first is that there seems to be a strong association between diabetes and poor oral health. So what happens is that if we call it as a two-way relationship, or it is bidirectional, whenever a patient is having poor oral health in terms of multiple cavities or severe gum infections, what happens is that their diabetes also, they have a poor controlled diabetes. So their glycemic control doesn't get, they don't respond well, and because of that, they will have also have increased incidence of diabetes. So with the uncontrolled diabetes, you also see severe gum infections, and also related to systemic diseases, other diseases like cardiovascular diseases. It is there is a strong association found, and it is said that the patients who have a poor oral hygiene, the three times prone for heart attacks and stroke. And another area is pregnant women. In case of pregnant women, if they do have a severe mouth infections, they tend to have preterm labor. They go into preterm labor, and thereby having low birth weight babies. So the list goes on. There are every day there are new conditions are added to this list, and it is very imperative and very important to follow good oral hygiene to in order to also maintain a good systemic health.
Yes, you have rightly mentioned, the connecting link between oral health and overall health, because everything that we eat, goes to our mouth first and then to other parts of the body. So, moving on here, I would like to ask Dr. Anish, sir, what are the benefits and limitations of different aesthetic dental treatment, such as veneers, crowns, and teeth whitenings?
Yeah, thank you, Dr. Ritika. Basically, aesthetic topic is a huge topic. From where to start and where to end, it's really difficult. And but to limit to this question, benefits are enormous because patient develops confidence once he has a good smile. Nowadays, you know that everybody is talking about aesthetics, everybody is talking about beauty treatments. People awareness has increased, the spending tendency has increased. I have seen in last 40 years there is a tremendous awareness increase about aesthetics in dentistry. Earlier it was there, but definitely now, earlier the spending mentality was not so much, which today we see people are ready to spend lakhs of rupees on their smile. It's a positive sign for dentists. It's a good news for dentists. But that doesn't mean you should get carried away with this aesthetic dentistry. Fundamentals of dentistry should remain. You should conserve the natural tooth. You should always select the aesthetic treatment which is related to saving the natural tooth structure rather than destroying the natural tooth structure. So there are a lot of advantages, limitations, I would say. One needs to understand before recommending these treatments before patient goes into understanding those treatment plan. All discussions are required. But just to list few, I would suggest that if you want to go for aesthetic treatment, first choice should be orthodontic treatment, which is most natural treatment where you don't touch the natural tooth, you don't give any artificial caps and artificial veneers, you don't go for any particular damaging that so-called tooth structure. Maybe it is a minimal damaging the tooth structure. But I would, as a dentist, I would say that I would prefer to go for orthodontic treatment for aesthetic treatment. But sometimes orthodontic treatment is not possible because of age, because of the bone condition, because of lot of limitation. And major limitation of orthodontic treatment is time consuming. It takes 1 year to 2 years to finish that orthodontic movements, and then that becomes difficult for that patient to decide about orthodontic treatment. So the choice comes if you want a quick treatment within 1 month, within 2 months, you want to finish your complete smile, you want to go for a smile designing in short time, then veneers, crowns, and teeth whitening becomes the choice for the treatment. Veneers, of course, is most conservative treatment because we remove the tooth structure minimally. But veneers, you can correct your smile if you have a lot of limitations and you have a minor changes in your smile designing. If you have a major changes in your smile designing, then it may not be veneers may not be the possible. This music. So veneers have limitations. It's a conservative treatment. It is advantageous. It can change your smile, but gross corrections you can't do it with veneers. That becomes a problem. Then you need to go for a extensive treatment like root canal treatment. When you remove a lot of tooth structure, the inside nerve gets damaged, and when the inside nerve get damaged, then you need to go for a root canal. There, the indication of endodontics comes in the picture. But if you want to go for a major corrections where proclinations, where rotation of the tooth, and all those treatments are involved, that time then crown becomes mandatory. Then crown becomes the choice of treatment. And when you go for a crown and when there is an excessive destruction, then maybe changing of anatomy, the root canal comes in the picture. So these are all depends on how much correction you want, how much quick treatment you want, and how much money you want to spend for your smile and correction. These all factors come in all in picture if you decide to go for a smile designing. And the lastly, you're talking about limitations and benefits of teeth whitening. Again, teeth whitening has a lot of limitation. Don't think that you bleach your face, you bleach your hair, same thing happen with your teeth. No, all the tissues are different, your facial tissue is different, your hair tissue is different, and your tooth is different. Teeth whitening is effective, it is successful, but there is a but, because teeth whitening depends on a lot of factors. First thing is thicker the enamel, better the shade, whiter the shade. Thinner the enamel, more yellowish teeth you get. So more the enamel, whitening is more effective. Less enamel, whitening is less effective. So depending on patient to patient, you may not get result in some of the patient if there is hardly any enamel left, especially aging patient. There the enamel is less, already teeth are atreated, the teeth are having erosions. So that becomes a problem for whitening. So whitening has a lot of limitations. It's not that easy like bleaching your hair and you are comparing with whitening of the teeth. But definitely it's a good choice, especially brides, all those bridegrooms, all those people who are going for celebrations, all going for public appearance. They all get a result with whitening. But major concern for whitening is sensitivity. You may develop sensitivity after whitening, depending on the case, whether you have any dental caries, whether you have a deep cavity caries. All those factors will matter in the long run for the sensitivity. And ultimately, once you do sensitivity with whitening treatment for those yellow teeth, that treatment may last for 6 months to 2 years. Then you have to keep on repeating and giving short whitening treatment for that particular treatment. And maybe you'll have to repeat those procedures for future continuation of that same shade. So this is a grossly you can talk about aesthetic dentistry, especially with veneers, crowns, and whitening. But as I told you, it's a big topic. But this is to start with. This is a good points to be discussed, and this is how we will plan for plan treatment for those patients who have a minor smile design correction or major or extensive bite corrections or smile corrections. So I
Thank
think
you
this the
so much.
explanation is enough to start your thinking. Thank you,
Yes,
Doctor.
thank you so much, Dr. Anish. You have very precisely concised all the things that are there in aesthetic dentistry. So you have mentioned that we have always maintained the natural condition of the tooth as it is before moving ahead to any cosmetic dental procedures. So in the same lines that you have told, that orthodontic treatment is the one which should be first done. So I would like to ask Dr. Shraddha that, ma'am, what are some of the challenges in providing orthodontic dental treatments to pediatric and adolescent patients, and how you address those in your clinical practice?
Well, ideally, adolescent patients, that age group is a better age group to start orthodontic treatment because the bone is a little malleable, it's more easily workable with these patients. The challenges for sure, especially with pediatric. First of all, it's a mixed dentition, right? I mean, it's not like all permanent teeth have erupted. If we're talking about before 12 years of age, then it's a mixed dentition. So we can't actually start proper orthodontic treatment. What we can do is we can do some skeletal modification processes so that eventually when we have to put braces, when the child becomes 12, then the extensive malocclusion or severity of teeth being maloccluded would be reduced. So in pediatric age group, which is before 12, let's say, there is limitation in orthodontic treatment because we cannot really put braces in the mouth. We can do very minimal things like bone modification to modify or to assist the already growing jaw bones in the way that would be suitable or appropriate. We can assist it. Now, the challenge with this is the child is not necessarily going to be very open to this. Yeah. And it depends a lot on the patient. We can't really, there's a limitation that a doctor can be involved because the appliance has to be worn for at least 17 to 18 hours in a day. And whether a child will do it, that's really questionable. So that's skeletal modification processes are challenging with these appliances in age group, but it does work. We see that. But eventually they do need orthodontic treatment when they do become adolescent. Just that the severity of malocclusion that we need to treat will become a little lesser if you start at an early age to and help modify growth itself. And then in orthodontic in adolescent patients, that's the right age group, I would say, because we can work with the bone in a more predictable manner. Let's put it like that. And it depends on who wants the treatment, whether parents are pushing the child or whether the child is wanting it. I mean, a teenager wants it to look better for himself. A lot of the treatment process and breakages and all those things that, because when we put braces in the mouth, we meet the patient once in a month or twice in a month, but then the braces is in the mouth of patients itself. When it is an adolescent, they're not so mature enough. If they're not self-motivated, if it is forced upon them, they're not self-motivated, then there is more chances of not keeping hygiene or breakages and these things. But if they themselves are motivated, then I don't see an issue in adolescents at all. They do it because they want it. And they take care of the braces. So the challenge of orthodontic treatment mainly is because we depend a lot on the patient's compliance. And in that age group, that is a major challenge. Let's put it like that. Yeah.
Yes. Thank you so much, Dr. Shraddha. You have rightly mentioned that compliance is the one issue, and second is if the patient wants the treatment or the parent one, but because that is the age group that we are dealing with is very tricky. And so we were talking about braces. So there is currently a lot of buzz around aligners in the market. So what do you think about those aligners?
Yeah, so I think it is great that we have this movement forward with aligners. It's definitely low maintenance, right? I mean, you don't have to keep it clean. Things don't get stuck so much. You have to remove it when you're eating, right? It's removable, so that's another plus. It's comfortable. It's much comfortable. There's no pricking or there's no wire jutting out sometimes in the middle of the month between appointments. Aesthetically, definitely better. Now, the challenge with aligners is that again, patient compliance is needed. Even if it is an adult patient, we totally depend on whether the patient will wear or not wear. Forget one day to wear, because 20 to 22 hours the patient needs to wear that aligner itself. Well, for something which is a malocclusion, which is very simple, let's put it like that, or moderate, then we can do it with aligners. That's great. But if there is something severe, which like there's a lot of spacing, or there is a lot of rotation, or there is a severe open bite, where you need to move the tooth as a whole and not just tip it. If you have to move the tooth as a whole, then there is limitation to how much we can do that kind of tooth movement with an aligner. So, for example, also finishing at the end of braces treatment, it's not just the crowns or the visible part of the tooth that has to be properly aligned. Also, so that the relapse doesn't happen, which is after you remove the braces over next few years, we have to make sure that we finish the root positions properly. Now, that movement of moving the root inside the bone it's a challenging thing, even with fixed orthodontics, like a normal traditional orthodontics. So, but that is a very important step in long-lasting results. So, with aligners, that kind of root movement for finishing, etc., root paralleling, uprighting of the roots, etc., it's very, very challenging, I would say, with the aligners. But yes, there is this plus, and why not when there is moderate cases or simple cases to go with something which is aesthetically pleasing, especially in adults. You would like it to be hidden. You don't want to show your braces. Great, but there are these limitations as well.
Right. So you have rightly pointed out what can be done with aligners and what cannot be done with aligners. So moving on to this aesthetic treatment, Dr. Anish, I would like to ask you, how do you foresee the future of aesthetic dentistry in India in the coming years?
Oh, that's a big question again, because I have been practicing for last 38 years, and I am seeing a tremendous change after post-COVID session. This era is giving a fantastic mileage to dentistry, which I could see in last 2 to 3 years. And of course, the overall awareness about health has increased in last 3 years because of COVID. This is a positive side of the COVID, that people have started understanding and realizing health as a priority. And that has given an advantage in dentistry. People want to have good dental health also now. And when you want to have a good health, you talk about aesthetics, smile designing, cosmetic treatment. And all I could see, there is a wave of awareness about beauty post COVID. I have seen a lot of activity happening for dental health. People are giving more attention to dental checkups. So if you ask me, there is a big wave for aesthetic dentistry in India in next few years. And I think that future is very demanding. And according to me, dentists should be prepared themselves and their clinic to attend this wave and take advantage of this aesthetic wave in next 5 years. That is what I feel. Because as Dr. Shraddha was saying, aligners are very effective. But the awareness of these patients regarding aligners is so much that I could see in my clinics, which I never saw in earlier years. Even 50 years old, 60 years old patient is asking me, can you move my teeth and make my smile better? Unbelievable it is. Imagine a 50 years old patient who has used his teeth for last 40 years or maybe 35 years, he wants to change his smile. Why sudden this approach has come in population? I don't know. I think this gives credit to WhatsApp also, knowledge, WhatsApp knowledge, Google knowledge, post-COVID psychology. All these have added to this dentistry, and I could see the awareness about health, awareness about beauty, awareness about looking fit, and awareness about smile designing has definitely increased. And only thing is how we can cope up this awareness, how we can fulfill them, how we can satisfy them by proper treatment, because there is a possibility of our dentistry may not be ready for the demand of what we are expecting from this population. So we need to gear up for all this activity, more awareness about dental treatments, different modalities for aesthetic treatment. All these things, according to me, is now in pipeline for all the budding dentists, for all the mature dentists, and all the senior practitioners like us who are now absolutely on a plateau and about to uh, conclude our practice. They all should be geared up to fulfill their expectation. So, if you ask me in one sentence, aesthetic dentistry is booming, cosmetic awareness is booming, and all dentists should be prepared and gear up for this, delivering these different modalities. That is the thing. Thank you.
Thank you so much, Dr. Anish. I hope this boom continues and not just, have a break or have
Dr.
a play.
Ritika, it is, I would like to add a point here. It is increased so much, the demand, that most of the dentists are getting trained to also deliver other cosmetic procedures to improve the facial
Right,
aesthetics, like
right.
fillers and, Botox and all that. So most of them are getting trained, and they are introduced that as a part of cosmetic dentistry nowadays. And that shows, where, it is heading, like,
We are
it
heading.
speaks
Yes, yes.
right now.
So in oral surgery now they have also added hair
Yes.
transplant into oral
No, not just
surgery.
oral surgery, even BTS graduates. BTS
Okay,
graduates also are eligible. So they train themselves with, it's a simple procedure. And
right.
their dentists, no, they're blessed with, I mean, local anesthesia, no. We give, it's like we are
Exactly.
trained
We don't
here.
have
So it's,
to. Yes.
yeah, there's no special training required. So yes.
Right. And plus the PRP injections and all
Yes,
the things are
PRF,
also coming into.
PRF, PRP,
Yes.
platelet-rich plasma, platelet-rich fibrin. They draw blood from the patient, their own blood, and then they
Their own blood.
centrifuge.
Yes.
Yes.
So yes, yes. So moving on to this only, I would like to ask Dr. Shanti Priya that how what role does toothpaste, OTC bleaching, and other OTC products play in cosmetic dental procedures?
Yeah, again, there's a huge market here. I mean, every day there are new products introduced in the market, and the demand is very high. So most of the times in our practice, when we look at it, people who come and seek cosmetic treatment, the main reason is, one is to correct the teeth, the malaligned teeth. Another one is the discolored white. Most of them want their teeth to be white. So this is a very, very common complaint, or the patient who seeks for aesthetic treatment. The first and foremost is whitening thing. And most of them would ask for something which they can buy over the counter, OTC products. So I would say that most of these toothpaste, which are available for tooth whitening, especially, they do not have any dramatic effect. Most of them do not give any great results. You have to use it for very long. And also, since they contain silica, an abrasive agent, which can also cause tooth erosion and sensitivity, so it's got its own side effects. So if they want something drastic, the improvement, they want to change the tooth color, then bleaching is the best option. But again, as Dr. Anish said, there are a lot of side effects with bleaching as well. And you need to understand, before we try to change the tooth color, what is the reason or etiology for it. Most of the times it's stains, and these stains can be extrinsic or external stains and the intrinsic stains. And external mainly because of probably smoking and tobacco, use of tobacco products or coffee, tea, all these things can lead to improper toothbrushing. All these can cause to dental stains. So this can be simply cleared by doing a routine scaling and polishing procedures, and then put the patient on a proper brushing technique, flossing technique, and use the right toothpaste. If it is intrinsic, maybe because of tetracycline or some drug-induced stains or fluorosis, which is again very common, yes, these patients do benefit from bleaching. And bleaching can be done either professionally or by personal, by a person can do at home itself. And you have a lot of these bleaching agents available in the market. All you have to do is go ask your dentist to give you some molds. You prepare molds for your jaw and you apply the paste, follow the directions given in the, at the back of the product, and apply it every day, and then you will see the result. So then let us discuss the negative side of it. Most of the times when you, without any proper guidelines, if you try to use it, it can cause a lot of chemical burns. So most of them should be applied in such a way that they do not touch the gums. If it extends there, then most of these products can cause some kind of a chemical burn. So you need to be very careful, follow proper advice, follow proper steps if you're doing it at home. If you're doing it professionally, we need to come for multiple sittings and we apply the bleaching agent with the help of heat or lasers. We can do the tooth whitening. But as Dr. Anish said, it is temporary. You have to do it repeatedly. And the side effect is it causes severe sensitivity. One has to be aware of this.
Right. They should not blindly follow,
Yes.
everything. They should consult their dentist first. So,
Yes.
yes, moving on to these aesthetic treatments, Dr. Shraddha, I would like to ask you that what are the different type of orthodontic treatment that are available for patient, and how you determine which treatment is right for each individual?
Well, there are few options, right? There are many options. So if you ask me, when a patient comes to the clinic, in a clinical practice, yeah, I'm not talking about theoretical practice. When you're in a clinic, when a patient comes to you, first of all, the most important thing is to understand where the patient is coming from, why the patient wants improvement on what front, and what is the real issue of the patient. Many a times we have this mindset of a perfect aesthetic look, like intraoral, and we need to make that perfect cant and the perfect golden proportion, and the buccal corridors need to be filled, or you have these knowledge of theory, but I think we have to really listen to what is the patient looking for. It's because there are so many factors. They speak about, I'm getting married in 10 months. I want this and I want that. So a lot of treatment needs to adapt to serve the patient's need. So based on what the patient needs, then you have multiple options in orthodontics, correct? So one, you can go for metal brackets, which is more visible. Let's put it like that. One which is ceramic, which is tooth colored, so it is not as visible. In ceramic braces, they are relatively more expensive than metal, but the treatment procedure essentially is the same, whether you go for metal or you go for ceramic. The treatment duration essentially is the same, whether you go for metal or you go for ceramic. But during the treatment, the appearance is different. Metal stands out a lot. Ceramic a little bit merges into the tooth color and it's not as visible. With ceramic braces, one can also opt for Optiflex or these wires which are tooth colored. Now, the challenge with that kind of wires is a little bit more friction and more time it takes for tooth movement to happen. But still, it is possible in certain cases. It's not an issue. There is other option, whether you go for metal or you go for ceramic, there is an option of self-ligating brackets. So this self-ligating brackets, which are within the bracket itself, you have certain hooks, which allows the wire to be attached to the bracket. The bracket is attached to the tooth. So You can have this kind of self-ligating clips in metal or in ceramic. Now, the advantage of this over a normal bracket, whether metal or ceramic, is that one can really keep better oral hygiene. I usually recommend this because the 1.5 years of having brackets in your mouth with so many wires and so many things going on in a traditional orthodontic system way of doing things, usually they come back at the end of it with some caries, many caries, which is because of lack of oral hygiene. It's not so easy to maintain. It's easier said than done. A doctor can keep saying it, but it's challenging for the patient, obviously, when you're using your mouth so much for your meals, and that's the main thing, right, in life, to eat. Uh, yeah, so you have metal, you have ceramic, you have self-ligating. You also have something called as lingual orthodontics, which can be an option. Now, for people who don't want their brackets to be visible at all, and the malocclusion, which needs to be corrected, is a bit severe, then not always we can go with Invisalign or clear aligners or these aligners ka option. Aligners can correct something which is mild or moderately maloccluded. And only tipping is this kind of movement. Only this kind of movement is easily achieved with aligners. But if the movement has to be like this of the tooth, like translated like a bodily movement, then because if there's a gap of 5 mm on both sides, then that bodily movement is needed.
Yeah.
So in which case aligners may not serve so much. Yeah. So what will happen is the aligners will tip it, and then the root will not move, and then it will open up as soon as you stop your treatment after 1 year or 2 years. Again, the gaps, etc. So for this kind of movement, and if it's a person who is in, let's say, glamour industry or is present, has to be presentable and cannot wear braces, then there is an option of lingual orthodontics, which is to put the brackets on the inside of the tooth. So it's not visible on the outside, but you can put it from the inside. Now, the challenge with this, of course, is the tongue space becomes less. And one has to, again, be motivated and have his own reasons of why he wants to do, say, lingual orthodontics or any of these treatments, because the success a lot depends also on patient cooperation in orthodontics, whichever options one may go for. These are the kind of braces or the kind of options for the treatment duration. But also, just to add, maybe you didn't ask me directly this, but these days in the market, because we're also talking about advances and moving forward and all of that, right? So one of the best ways to, I'm seeing the future, and I'm thinking, how can we make the process, as soon as the patient comes, the process faster of diagnosis? How can we make it more accurate? So one of the things, I think, the 3D facial scans that are coming up, that's really, as Dr. Anish was saying, that we really do need to catch up with these things, because there are these intraoral scans where you don't need to make impressions. You can just scan it and you have the model, right, on the soft copy. And then you have these facial scans. So a treatment planning also becomes much efficient. People can opt for these kind of options as well, where treatment simulation can happen, and you can quickly show pre-treatment and post-treatment. Okay, you have 10 months, you have this much. You can already do it in CAD/CAM, and you can show the patient, okay, this is what we can achieve in this much time. Yeah, and these are the different options that can be. So these are very handy, I would say, to speak to for communication with the patients, for also interdisciplinary communication with the labs. Yeah, so I think we really can move forward. And like we were just speaking about Botox and all of that, we cannot really be focused today only on the inside of the mouth and correct all that, because with all this, all the cant corrections and all of that can be imagined even before treatment starting, and we can show the patient all of this. But in addition, the high lip lines and all of that, Botox and all of that, is there in the future, where to correct some, not just the teeth, but also the relation with the how the face is, the soft tissues and all. And that's also something, possibilities and moving forward in orthodontics and cosmetic dentistry. Yeah.
Right, you have very, briefly explained all the procedure that can happen. I remember when I started in my first year, a lot of girls were there who started their orthodontic treatment in first year, and their treatment concluded at the end of third year. And then they used to wear. So I also got to my HOD, orthodontic HOD, Dr. Deepak was there. So I told him that I have a crooked teeth in front, and I want to have it done orthodontically. So he said that you require, you have class 2 malocclusion, you require surgery, because I think my chin was backwards a little. And so he suggested that what you can do is just go for veneers. Just go for, you just have a problem with only one teeth, one crooked teeth, you can go with either veneers or crowns. So that will simplify. You don't have to go through the surgical procedure yet. But I think there are a lot of technology that has come into play, that people can see what their smile will look like. That you would,
Yes.
simulation of what reality will be after this much duration of treatment.
Yeah, this also includes skeletal, like you said, the 3D scans, etc., will allow us not just the soft tissue improvement, dental improvement, but also allow us to see if skeletal, addressing the skeletal issue, how much can we address and what. So, for sure, skeletal issue cannot be corrected dentally. It can only be camouflaged dentally.
Right.
Skeletal issue can be corrected only with surgeries, but if it's not so severe, then it can be camouflaged dentally, for
Right,
sure.
right. So, moving on to these smile designing, and we talked about this. I would like to ask Dr. Anish, what is the role? So, what is the role of root canal treatment in smile designing?
Yeah, there is a big role of root canal in smile designing, because nowadays we are talking about digital dentistry, we are talking about minimally invasive dentistry. All these concepts, they come together where we talk about minimal treatment required to achieve the final result. Now, question comes that sometimes the minor corrections you can do it. I already mentioned that with veneers and smaller corrections with some composite laminates or maybe ceramic laminate. But big corrections, whom orthodontic treatment patient doesn't want to go, though it is possible. But because of the duration of 1 year, 2 years, and 3 years, patient sometimes is reluctant to go for orthodontic. Then comes the major correction in your smile designing by doing more cutting and maybe removal of natural tooth just to achieve that smile designing. My only opinion is one should not get carried away with this aesthetic treatment to lose the fundamentals of dentistry. But wherever there is a requirement of root canal, where there is a more destruction, where there is a damage of potential damage to the nerve, there root canal comes in the picture. Root canal is also indicated whenever it is possible. I would suggest if you do proper root canal, tooth can last for 20 years, 30 years. You need to understand endodontics also. Like I told you, you have to gear up for this wave. Similarly, you have to gear up to save that natural tooth. Endodontics plays a major role in saving the natural tooth. So there, if you are well trained in endodontics, even a BDS doctor can do good root canals. I am sure about that. But then, if you are good at that, your prognosis and the longevity of your aesthetic treatment goes much longer for 20 years and 30 years. And that is what is required. So, role of RCT's root canal treatment is very important. There are different types of treatment plans where intentional root canal is requirement. They call it as a prophylactic root canal, which I feel, again, it is on a clinician's discretion whether root canal is really required or not. All malpositioned teeth, all big cavities, they may need a root canal during that smile designing. But ultimately, root canal should be done properly, like going into full length, proper cleaning of the root canal, then only your aesthetic treatment will go for a longer duration. So I feel all treatment plans will have somewhere 1 or 2 root canals involved if you want a quick treatment, not orthodontic treatment, or wherever there is a crown. But
and visit your dentist at least for an annual checkup, and also avoid any of these junk foods and smoking, tobacco, and all that. If you follow these steps, definitely you can have your own natural teeth throughout your life.
Thank you so much, Dr. Shanti Priya. Dr. Shraddha.
I think everyone is beautiful, whether the teeth are crooked or not. But we do have advances in technology, and we can definitely help you from a technical point of view. If it's an aesthetic, if you want to enhance your beauty, which you already are. If there's a functional issue, then you definitely should address it first, like deep bite or something like that. So if it's causing a functional biting issue or something like that, definitely you should address it, because that affects everything else in the body system.
Yes, so with this, thank you so much, Dr. Shraddha. With this, I would like to conclude this oral health summit here. And thank you so much. I would like to thank the eminent speakers for taking time for this important and crucial discussion. So thank you so much, Dr. Anish, Dr. Shraddha, and Dr. Shanti Priya. Thank you so much.
Thank you very much.
Thank you, Dr.
For giving us an opportunity
Thank you, Dr. Shraddha.
to discuss
Thank
about
you, Dr.
these.
Shanti.
Thank you,
Thank you.
Dr. Anuj. Thank you, Dr.
Thank
Bye.
you.